Well, I think I'll go ahead and start, just so that we don't lose time. We have such a substantive couple of panels here, and I just want to welcome you and thank you for joining the effort to build a national movement to prevent trauma and foster resilience. There are three organizations that have really led the effort here, have organized and coordinated this series of workshops. There are 8 of them altogether. The last one began 2 Fridays ago. There'll be this one and then 6 more every other Friday from 1 to 5 with a breakout from 5 to 6, and that's Eastern time. So please join all of them if you can, but they'll be made available to you if you aren't able to join all of them. So there's the 3 organizations: the Campaign for Trauma-Informed Policy and Practice, the PACES Connection, and the National Prevention Science Coalition to Improve Lives. I represent the latter organization. My name is Dr. Diana Fishbein, AKA Denny, and I'm the co-director and the founder of this organization. And I'm also at the University of North Carolina in Chapel Hill in the Frank Porter Graham Child Development Institute, and I'm part-time faculty at Penn State University. This is Jesse Kohler. He is the executive director of CTIP and has been instrumental in organizing this series of workshops, and in fact, the entire national movement. Jesse, would you like to say anything to our guests?
Just want to quickly welcome folks and thank them again. I was literally moved to tears during the last workshop session and expect to be again as we see this movement continue to grow, and that's because all of you are a part of it. I just want to quickly acknowledge, and Denny will get to this as well, that through the survey response, we recognize that this workshop series is a little bit like drinking from a fire hose at times, right? It can be a lot of information, and we are working to continue to improve the format and model moving forward. You'll see that as future sessions evolve. One thing that we're doing to help ameliorate that, because the next few workshops, we do already have the speakers lined up and wanted to respect their time and what they've given in their preparation, is that we will be showing the second half of every workshop the following Friday and having the breakout discussions after that. So if you feel like 4 hours is just too much, we totally understand, or if you just can't join the second half. And we'll be showing that the following Friday. So expect another email from me at jesse@traumacampaign.org, and I'll send a link that everybody can join through that. We'll share the screen and go through that. And then we'll have our own breakout rooms following that second half of the session, if that works better for folks. Thank you again for being here. I don't want to take up too much time because most importantly, we've got to get to our wonderful panelists, our 2 great panels today. So Denny, I'll kick it back to you, but thanks so much again.
Absolutely. Thank you so much, Jesse. So I also want to introduce Jane Stevens, who is a co-conspirator with the other 2 organizations. She's the founder and now the previous CEO of PACES Connection. She has just handed over the helm to Ingrid Cochran, the new CEO of PACES Connection. Ingrid will speak in our next workshop. We'll give her several minutes to describe the movement that they have been promoting for quite a number of years now. And so we're thrilled for our 3 organizations to be working together. I also want to show you this slide that shows all of the various organizations that are co-sponsoring this series of workshops. I'll give you 1 second to just take a look at the organizations that have helped to make this happen from all over. Some of them are national organizations, some of them are research centers, and so forth. Okay. And now I would like to introduce to you Dan Press. Dan Press is the brains behind the brawn in this entire movement and in the workshops. For 40 years, Dan has provided legal and Washington representation assistance to Indian tribes. And I've, by the way, noticed that there are some Indian tribes represented here today. Indian organizations and companies doing businesses with tribes. Dan has used his years of experience working with tribes and private sector companies to assist his clients to develop productive business partnerships with tribes so that their projects can move forward quickly and cooperatively. Dan serves as a pro bono general counsel for CTIP and the Roundtable on Native American Trauma-Informed Initiatives. In November of 2018, Dan received the Public Advocacy Award from the International Society for Traumatic Stress Studies for outstanding and fundamental contributions for traumatic stress studies, for advancing the social understanding of trauma, and is the author of a how-to handbook on creating comprehensive, integrated, trauma-informed initiatives in Native American communities. Dan.
Thank you, Denny. Thank everybody for joining the call today. The purpose of these workshops is to move the movement forward. The movement has just been incredible over the last 10 years. Thanks to all of you. There are hundreds of trauma-informed local coalitions that are working to make their communities trauma-informed, and there are thousands of individuals who are doing the same. The next step in the movement is to bring all of those powerhouses together into a coordinated effort. So the trauma movement is a force at the Washington congressional level and is a force at the grassroots level. And to connect the local coalitions, the three organizations Denny mentioned have created a new entity we're calling the Coalition of Local Trauma-Informed Coalitions, with the purpose of bringing everyone together in two places. One, the three organizations will serve as the voice for the trauma-informed coalitions in Congress, advocating for funding for trauma-informed coalitions and other trauma-informed legislation that the local coalitions tell us they want us to work for. At the same time, the coalition of coalitions, three organizations, will help each individual coalition with materials so you know how to go lobby and advocate with your local Congress people, setting the stage at the local level. So between the Washington work of the three organizations and the local work of the hundreds of local coalitions, we think we can create a groundswell for trauma-informed funding and trauma-informed legislation. The coalition will also provide forums in which the hundreds of local coalitions can share their experiences, learn from each other, and really support each other. That includes the work of PACES Connection, which is already doing so much of that, and the CTIP CAN monthly calls that you can learn about on the CTIP website, giving people an opportunity to learn what innovative programs are going on. So what do we need you to do? If you're a local coalition, we need you to sign up with the national campaign. Denny, are you putting the slides up? Oh, I can't hear you. There should be a slide showing how to sign up. We need every local coalition to become a member of the coalition of coalitions.
It's there, Dan.
Okay, it's not on my screen. All I see is Penn State, but okay. So if you're a member of a coalition, please sign up and become part of this force that's going to change the way Congress and the way the grassroots communities learn about and know about trauma. If you're not a member of a coalition, we ask you to try and find a coalition in your community and join it. If there is no coalition, we ask you to create a coalition. And if you go back to last Friday, the 2 Fridays ago session, there was great advice on how to create a coalition. And if you can't become part of a coalition as an individual, you can join the national campaign and become an advocate in your community with your local elected officials. So everybody on this call has a role in this new step forward for the movement. Join the national campaign as a coalition, create a coalition, or join as an individual. But if we really want to make the difference we all want to make in this country, we need to be a force. And the way we're going to be a force is through a coordinated effort, and the coalition of coalitions is our at least initial effort to create that force. So we look forward to working with all of you. And again, thank you for joining this call today.
That's great, Dan. And to the audience, if you don't have time to jot down these links, we will submit them to the chat so that you will know how to join the campaign. Okay, so for today, this is our agenda. We have a number of outstanding speakers in both panels. The first panel will address the education system, ways in which we can make it trauma informed. And these are the speakers that we will have. Lee Johnson will be introducing them. So this will come back to you in a few minutes. And then the afternoon later at 3 o'clock, we'll have address the healthcare system. And these are our panelists, our speakers for that. And that will be led by Dr. Sandra Bloom. So before I introduce to you Lee Johnson, Dr. Johnson, just a few housekeeping things. Feel free to use the chat to exchange with one another with such a large group of people in attendance. The chat will go by like wildfire, and it might be difficult for us to monitor it, but I think submitting your comments and your exchanges in the chat is a great way for us to feel like a sense of community. And we will print the chat, we'll save the chat, and we'll look for substantive comments later after the session. Also, as speakers take the stage, I will be putting their full bios into the chat. So please know that when they're introduced, the bios will be quite short, when in reality, they're very long. They have lots of credentials. And so we'll put them in the chat so you can read them. If you have questions, please submit them to the Q&A and not the chat, because we can't monitor the chat given how quickly it goes by. But we will try our best to address questions that are submitted to the Q&A. Also, the invitation link that you've used for today and perhaps last time, it will be the same link for every workshop. So store it somewhere safe so that you will have ready access to that for subsequent sessions. Also, all the resources that we are referring to or showing you during the course of these workshops will become available on our respective websites, CTIP, PACES, and NPSC. So check those websites often for additional submissions for you to look at. You can also expect an email asking you to complete a very brief survey afterwards so that we can evaluate our efforts and make sure we're meeting your needs. The link will also be on the websites. And if the session ends too soon at the very end, before we get to a breakout room, and let's say I get off and you've lost the link that was submitted to the chat, you can also go to one of our websites to find that link. And it's on the mpscoalition.org website. Also, as Jesse already said, the recordings will appear on our website in a few days after each workshop. But note that we will replay the second half of this session next Friday. Okay. Let me now introduce to you Lee Johnson III, PhD. He's Senior Policy Analyst for Infant and Early Childhood Mental Health at 0 to 3, the national leader on infant toddler policy and program development. He works with the Director of Infant and Early Childhood Mental Health Strategy, along with federal policy, state policy, and advocacy leadership staff to develop and implement 0 to 3's federal and state policy positions. So I am going to stop my share and allow him to do so.
Thank you, Denny. Can you hear me okay?
Yes, everything's beautiful.
Awesome, awesome. Well, first I would like to say thank you to everyone taking part in today's workshop series. I want to give a special thanks to Dr. Denny Fishbein, to Dan Press, to James Stevens and Jesse Kohler for the extraordinary support throughout this workshop process. I also would like to acknowledge all of you joining us today near and far. I could see from looking at the chat, some of you joining us I've known for just a little while, and some I've known through correspondence for many years. I'm mindful of the variety of feelings, the variety of blessings which you bring to this moment, and I'm grateful to be with you. My name is Lee Johnson III, and as Dr. Fishbein has shared, I work at 0 to 3, and I've been given the marvelous privilege of setting the stage for today's incredible workshop. And I thought that that is exactly what early relationships do, set the stage for later development, which I will talk about today. And in this moment of stage setting and thinking of early relationships, I'm incredibly proud to represent 0 to 3 today, who is committed to being an ever-present and reliable force for keeping babies at the center of our work and continuously strengthening our relationships and connections with you and all the professionals working to ensure babies and toddlers have a strong start in life. Though in speaking of at the center, when I think of babies, I think of the preschool children they soon become, the teenagers that grow up to be, and the adults who walk among us navigating this wild, wondrous thing human existence is. Many of these adults are caregivers, much like the ones in the picture you see here with obvious delight. And other adults make up the village that surround young people, like all of you. So I want to give a special thank you for all of the work you all do, especially with all that is going on in the world. In keeping with this theme of setting the stage, 21st century science is clear that all brain function that sets the stage for later development is a direct result of an interaction between genetics and the environment. And brain science explains for us why the first 1,000 days of life matters so much for children's development. With 85% of the brain developed by the age of 3 and 92% developed by the age of 5, what this shows is that brains are being built during this critical time of growth. And the first 5 years lays the foundation for everything that follows. And that foundation can be sturdy or fragile, as I'm sure all of you are aware, depending on a child's experiences and even more their environment. The current moment that we are all finding ourselves in right now demands that attention and consideration is given to trauma, to the impact of COVID-19 and these kinds of traumatic eruptions happening in the world, being witnessed by babies, by preschool children, by teenagers, and all of the adults walking around among us, navigating this wild, wondrous thing human existence is. When I look at the picture charting brain development from the previous slide, I think about my own life and have become acutely aware that childhood is not an adventure we choose, but that it is chosen by adults, familiar and forever unknown, through the experiences they create for us. Whenever I look at these photos, I will never forget the sense of wholeness I felt when I realized what, in fact, I really was. Not just an early childhood educator or a state director or a student of human development or a policy analyst, but I was someone who experienced positive and negative things throughout my childhood and into adulthood, and someone who would later use every single talent that I had ever been given to me in the service of children and their families. I can tell you that it was that particular focus that made all the difference. I can also tell you that none of that was written on the back of my college diploma. It's a miracle when we finally discover whom we're best equipped to serve, perhaps from those early positive experiences, where we can also best appreciate the unique life we've been given. And that profound discovery came through my early relationships and development. And a major premise in supporting early brain development and the relationships that foster this development is a concept I like to refer to as one that sits at the intersection of all things child well-being, and that is infant and early childhood mental health, which is defined as the developing capacity of a child birth to age 5 to experience and express and regulate their emotions, to form close and secure attachment relationships, and to explore their environment, all within the context of family and the community. I like to acknowledge that we often use the terms infant and early childhood mental health and healthy social and emotional development interchangeably. I would be remiss here to also mention that very young children can and do experience serious early childhood mental health challenges, with children ages 0 to 5 experiencing at least one social, relational, or behavioral health disturbance during their growth and development. You know, one of the wonderful things about this workshop series is an opportunity to highlight all of the ways that we can promote social and emotional well-being. In my role, my work falls primarily in the policy space, as you can see on the graphic on the slide. And there are others here that have joined us across the US whose work touches children's lives from other avenues of connection. I wouldn't be surprised if there are some areas on this particular graphic that you are familiar with in your work. Early childhood is a critical time for brain development. And to the earlier point about setting the stage for cognitive, social, and emotional development through childhood, this development of infants and young children is intertwined thoroughly with the quality of the caregiving relationships in their lives. And whether you're working with infants, toddlers, preschoolers, teens, adults, we can all acknowledge that we deserve to have the freedom, self-determination, and support needed to grow and learn. While I have the time, I'd like to acknowledge that I've placed here 2 photos of young children posed as incredible Black historical figures as part of the Because of Them We Can initiative founded by Unique Jones. It is my way of honoring their legacy and giving a nod to their resilience and a personal reminder of who all this work is for our young leaders. In the photo on the left is of a child posed as Frederick Douglass, who was an American social reformer, abolitionist, orator, writer, and statesman. And on the photo on the right is of a child posed as Angela Davis, who was an American political activist, philosopher, academic, and author. She is a professor at the University of California, Santa Cruz. So I invite you that whenever you have time to explore their story, I encourage you to do so and to think of them in your efforts to mobilize, to promote trauma-informed, resilience-focused, healing-centered approaches to support your community. What this often makes me think about is something that I heard one of my heroes say, who you probably are aware of, Mr. Fred Rogers, and that sometimes it seems like we've forgotten what it's like not to be able to reach the light switch. And that this path towards a greater truth requires a disciplined relearning of what we already know, whether it's about trauma, whether it's about resilience, and whether it's about healing, but must now rediscover in a time of COVID. And I also want to leave with you something that I would be remiss not to share, is that if you would like to get involved with 0 to 3's advocacy in supporting babies and their future, I encourage you to sign up at thinkbabies.org. It is a way to stay up to date on some of the policy efforts that I've been engaged in and other colleagues of mine to support babies, where it provides a resource for you to email or tweet your member of Congress, to share information about infant and early childhood mental health, to broaden information about networks on social media, and other ideas that you may have that your members of Congress need to know, quite like this workshop series. I also want to provide for you my contact information and also take this time to end my part of my presentation, but pick up where I left off by sharing that Dr. Iheoma Iruka will be joining to follow up to what I've shared to discuss how might we support trauma-informed, resilience-focused, and healing-centered approaches in the early childhood education space. So I'm going to take this time to introduce Dr. Iheoma Iruka, who is a research professor in the Department of Public Policy, who is a fellow at the Frank Porter Graham Child Development Institute, and the founding director of the Equity Research Action Coalition at Frank Porter Graham. She is leading projects and initiatives focused on ensuring that minoritized children and children from low-income households, especially Black children like the ones I showed you in the photo before, are thriving. Dr. Iheoma Iruka, the floor is yours.
Well, thank you so much, Dr. Johnson. Thank you for welcoming me. And of course, want to take time to thank Denny Fishbein, Jesse Kohler, Dan Press, and really all of the partners. And of course, most importantly, you. And, Lee, you left me just speechless. Luckily, I don't have any, mascara and all that on kind of, that I was just, make sure you read the chat box. There's so much just love going to you, but also what you are sharing. And so I thank you for sharing your story. And I'm just so honored to be here with you all. And so I'll just take a few minutes to just share a little bit, but I look forward to hearing from my other co-panelists, but really this whole entire group of people who are joining this movement, because in the end of it, a movement is necessary if we're trying to center the humanity and the justice of young children. So I want to make sure that we recognize why we are here. And so I have a few remarks, if I may, to share with you. And so I sort of titled my remark, Centering the 3 Ps to Address Racial Trauma, Asset-Based Programs and Policies that Support the Well-Being of Racially Minoritized Children. And before I kind of just give my few remarks, I do want to ground my remarks in who I am, because my personal identity is my professional identity. I know it's not often you hear researchers talk about personal and professional, but I think it's important that as we think about any sort of movement that's focused on resiliency or trauma, that we understand that we, each one of us, is a person, is a human, and that we have to see our own humanity in order to also be able to uplift others who may not be as fortunate. And so I actually show you this particular figure. I actually use it in one of my anti-bias, anti-racist sort of culturally grounded work to remind us that for you to do the work, you have to know your privileges and also areas that you may not be as privileged, right? So I, again, as we shared my bio, right? I'm a professor, but there are other things, right? I'm a Black mother of young children. I'm a wife, I have a degree, right? I'm also food secure. I speak English. I'm a US citizen, right? So there are things, identities, right? Heterosexual, able, all these things that I understand, right? But I also come to you as a child of immigrant parents who grew up primarily in a single family home, where I, experienced the depth of poverty, where, we lived in other people's home, lived with other people, living in 1-bedroom apartments, right? We use food stamps and all of the social benefits from free reduced lunch, WIC, et cetera. And I presented as a Black person who spoke English, but I was an unidentified dual language learner because my home, we spoke a language other than English. And so, and also spoke different variations of English. However, I could speak to the village that I had from a strong mom who worked 3 jobs and was really never home, but also to teachers and educators. Like I think about Miss Wilson, who called me Dr. I squared when I was young. I was like, oh my goodness, really? Right? And when the teacher sees you from before you even see yourself, right? To Miss Middleton, who, made sure that we read Richard Wright, right? Who made sure we read Martin Luther King, who ate, garlic. So I come to you, with privileges, but I also come to you as somebody who lived a life of adversities in many ways, but who should not be viewed from the adversity, but from the asset. And that's what I'm hoping comes with this remark that I have for you, is that don't just see the face, but also see the experience, but also the asset that comes from those experiences. Living in the way I lived as a young person, being one of 7 girls, losing 4 brothers before and after birth, those are part of my own story that shapes my professional identity. And now that I return to UNC to launch the Equity Research Action Coalition, my personal pushes me to do this work, which is really focusing on co-constructing actionable research with practitioners, professionals, and policymakers to really support the optimal development of Black children and other minoritized children, really starting before they're born. Because as Dr. Johnson has pointed out, a lot happens before children are born, but also in the first few years of life, right? The 1,000 days in particular, but also the 2,000 days, right? The birth to age 5. And also it's really important that we do work at many intersections for me, particularly around research, program, and practice, using both an anti-racist and a cultural wealth framework. To me, you cannot deal with trauma, you cannot think about resilience if you don't think about the systems of oppression, but also think about the assets and the cultural wealth, AKA the resilience, like Black joy, excellence, that we have to think about, right? How do we bring those two things together if we're really trying to support the best of children, the best of families and communities? And I wanted to recognize, at least for me, I clearly study work really around Black children and other racially minoritized population. And we have to understand the reason I do that, because I believe, and we know from the data, that racism is one of the root causes of trauma, right? So I'm showing you this particular figure on the right from the Racial Equity Institute. And I sort of, it's an easy sort of graph to follow, in that it really lays out that across many systems, from health, education, criminal justice, child welfare, and finance, that we do see from all of our data that Black people are 1.5 to 7 times more likely to have bad outcomes across systems. For example, we know that Black babies are likely to die before birth. As I've already told you, I lost 4 brothers before, right after birth. We're at least 2 to 3 times likely to, born preterm or low birth weight, which has other downstream effects. Likely to lose your mother, right? We have a huge racial disparity when it concerns maternal mortality. I don't have to speak about education, I will a little bit, but we do know we have issues of the cradle to grave, really around the school to prison pipeline. We do know all about the suspension expulsion data, but really even within that data is really the idea that you're being told as a 36-month-old, as a 40-month-old, that you do not need to be here, right? That you are not deserving of equal access to sort of these early learning opportunities that again build brain development, that again set you on a course for life. And so when we know that across every single sector and system, that Black people in particular are likely to have bad outcomes no matter what, tells us that there's a root cause of those experiences. And we know from our data thus far that racism does lead to trauma, right? Racism and race-based traumatic stress present with a variety of symptoms, and they have lifelong consequences. I mean, talk to probably any Black person, and you will realize that some of their experiences in one instance is being told, you cannot go into that pool, you cannot go to that neighborhood, you cannot attend the school merely because of your skin color, or being told that you should not play here, right? Being spit on, as we're seeing today. That's today, right? This is not 1965. That actually, we can see it being visited on adults, and that impact has lifelong consequences that we're seeing today, right? From all of the health indicators we have. So we do know that racism impacts children, right? But we know that because Black children and youth are particularly vulnerable, because the point of it is that they don't have the language or the cognitive skills at this point in time to really connect it, right? Think about us as adults. We barely know what racism actually is, right? It has many forms, from systematic all the way to internalizing. We don't even know that it's living in our system until pretty much we're older people, I should say, mature, right? In many instances, we don't even have the words for it. So imagine a young child experiencing it and how they're supposed to interpret that and take that on. And we know also that as early as by the age of 3, children know themselves in racial ethnic terms, right? As a mother of a Black girl and a mother of a Black boy, my kids literally know what color they were by the time they were 2 and 3, right? They often talk in some instances about, I want to be a different color because I see how others react and treat them versus me. That sends a message to children that is internalized and has mental health consequences, and of course has impact on their engagement in school and other things as they continue throughout their adolescent and adulthood. We need to understand that a lot of that starts pretty early, and based even on our infant data and our infant mortality data, we know that racism is impacting children's viability as a fetus and eventually being born. And of course, as a researcher, I'm always going to say we need more research to understand the manifestation and impact of racism on children's development and how it leads to overall children's well-being. But from what we know thus far, we do know that it's a pernicious impact that we have not fully comprehended and actually fully addressed. And so I'm very excited to see this movement talk about early childhood, but also talk about early childhood in terms of trauma, but also in terms of resilience, right? To me, when I say that part of what I do is try to sort of balance, yes, we need to for sure address racism at all of its levels, but we also have to think about what is it that minoritized populations, including Black people, have been doing in response to being denied housing, loan, education, humanity, right? There are responses that communities actually do. And for Black people and other people of color, there are cultural assets, and I call them resistance assets, that you bring when you are being denied opportunities, access, and experiences similar to those who may not look like you, right? And so I sort of encourage you all to think about this work from Yoso, who's also University of California, who talks about the 6 cultural capital that many minoritized populations bring from aspirational, right? Think about it. For example, Black people were denied access to education, but they were willing to send their 5 and 6-year-old to integrate schools by themselves, while adults and children and youth spit, call them names. That is when you have aspirations beyond that you can even see, right? So to me, we have to look at the resistance and the assets that people bring, even in the face of trauma and inequities and oppression, right? So he also talks about various categories of cultural assets, including navigational capital, linguistic capital, right? The fact that people go through code switching, as we call it in the Black community, or multilingualism, as we see with other communities that speak a different language other than English, and other ways that you continue to inoculate your children and communities from the oppression that they're likely to experience over time, or even family capital and social capital. So again, I call on us to think both about how could we continue to address issues of racism at all of its levels, from systematic to interpersonal, and the biases that we continue to experience, to even internalize. And when you internalize that, what people say about your community being lazy, less than, not American, how that impacts children's own sense of self, but also layer on with what are the cultural assets that we know is grounding children, and hopefully inoculating them to some extent before they really face society. And so I just want to introduce you to really what I say as a 3Ps framework of protecting, promoting, and preserving. And because to me, knowing that trauma creates both social and biological vulnerability to Black children and some other children of color, we need to make sure that strategies and policies really focus on how do we protect our young babies from harm and trauma? How do we promote their health, economic stability, mobility, really wealth, and also access to educational learning opportunities like childcare, early childhood, preschool, and then how do we preserve their cultural heritage, language, and family units? To me, if we're not grounded in protecting and promoting and preserving the best of children and their families, then we are not doing what I call trauma-informed care, because we need to protect children before we can promote them. And part of that means that we have to preserve the best of who they are. in many ways. And I'll just briefly highlight a couple of policies that we know in particular seem to work in terms of protecting the well-being of Black families. And it includes things like expansion of healthcare, particularly Medicaid insurance, because it provides access to both pre-birth medical services. And so expanded access to Medicaid is really important, particularly for maternal mortality and reduction in preterm and low birth weight. So we need to begin to attend to that. But again, we need to attend to how do we address issues of civil rights protection and criminal justice, because while that may impact adults, it impacts children because the adults in their lives and those around them are protected. And then I want to flag some promoted policies like earned income tax credits, because we know that that seems to be really important for Black families, and state minimum wage because they reduce poverty for Black people, as well as paid family leaves, because we know that helps to support Black parents' breastfeeding practices and also support their mental health. Again, I'm just flagging some things that we can continue to focus on, because we know when mothers and fathers and adults and children's lives are well, children are also well. But I will also flag other policies that we haven't addressed, like mortgage insurance, baby bonds, universal preschool writ large, at least starting at 3, if not earlier, at least access to that. And then finally, what kind of preservation policy should we be thinking about? Again, when I think about preservation, how do we preserve the family unit, right? Because we do see a large number of Black and Native children are being separated from their families due to child welfare policies. So what can we do in the early education space, whether it's through workforce coaching, workforce diversity and compensation, curriculum, to make sure that we are preserving children's sense of self, their racial identity, their language, their cultural heritage. And then finally, I leave you with an opportunity to engage in the Black Child National Agenda that was released in November with the National Black Child Development Institute, that says that there are some things that we can do to make sure that we're not positioning children to be traumatized, both themselves, but also their families, from things like child tax credit, from things like access to the Medical Leave Act, health insurance, early intervention, et cetera, et cetera. So I urge you to engage in that. And finally, I leave you with this notion, and I lean into Malcolm X, because like me, I am a social justice researcher. I'm doing research for a purpose, and I'm using research as a weapon for change and weapon of humanity. To remind you that I speak like this, not because I'm anti-white, but it's because I'm anti-exploitation, anti-degradation, and anti-oppression. It's about humanity if we're dealing with resilience. So again, I thank everybody for having me here and look forward to hearing remarks from my other co-panelists.
Thank you. Thank you, Dr. Iruka. I thoroughly enjoyed your presentation and many of the things that you've shared about preserving, about protecting, and about preserving, and about promoting policies that strengthen Black families and really honor their humanity is extraordinarily needed in this time. And so thank you so much. We will all have an opportunity to share questions. And of course, you are encouraged to share questions in the Q&A, but also in moving our time together along with each other, I want to introduce our next panelist, who happens to be David Adams. And David Adams is the CEO of the Urban Assembly. As the Director of Social Emotional Learning, David sits on the board of CASEL and is an author of the Educator's Practical Guide to Emotional Intelligence, and a co-author of the textbook Challenges to Integrating Diversity, Equity, and Inclusion Programs and Organizations. David Adams, the floor is yours.
Well, thank you so much, Dr. Johnson, and thank you to CTIP for having me here today. I'm very excited to be here to talk a little bit about the relationship between social emotional development and trauma-informed practices. I'm going to share my screen here so that we can get this started. All right. Let me get this here. So as Dr. Johnson said, my name is David Adams, and I am the CEO, Chief Executive Officer at the Urban Assembly. And what I'm going to do right now is spend the next couple of minutes, about 10 to 15 minutes, talking about the relationship between trauma and social emotional learning framework as an understanding or a concept for developing whole child approaches. A little bit about myself. I started my career at the Rutgers Social and Emotional Character Development Lab, moved to the Center for Social and Emotional Learning, spent some time at the Yale Health Emotional Behavior Lab, spent some time in District 75 here in New York City, which is our district for students with severe disabilities. Moved to the Director of Social and Emotional Learning at the Urban Assembly, spent some time as the Senior Director of Strategy, currently the CEO. And between that time, I've also spent time on the Aspen National Commission for Social and Emotional Academic Development, as well as the Castle Board of Directors. On my free time, I am in the Army Reserve, captain as a U.S. Army Civil Affairs officer. Now, before we get into this conversation, I just want to let people know that the machines are learning. Now, I don't want to alarm you. I don't want you to feel weird, but I do want to let you know that the way that machines and computers have been learning has shifted over time. It went from programming in which we told the machines or told the computers how to do things through code to a new way of understanding. When we think about artificial intelligence, in which machines take in information, huge amounts of information. One might even call it experiences. And from there, they do two things. Either they learn, they predict, and then they use that information to improve. Now you may think that this is a new approach to learning, that it takes a computer science degree to do it, that it's never been done before. But in fact, this approach to learning is not designed for computers per se, but it's based on our brains and how we learn. You see, the human brain also thrives on interactions. It's called the Hebb rule, that neurons that fire together, wire together. And as Dr. Johnson said a little bit earlier, it's the environmental inputs in our experiences that switch genes on and off with regards to gene expression and epigenetics. And lastly, it's the chronic stress levels, cortisol, that impact the size and the brain development of the frontal cortex. So when we think about artificial intelligence and all of your newfangled technology, I want us to understand that this is not based in science fiction. It is based in our understanding and advancing understanding of how we learn as people and the role experiences play in that learning. Now, we know that the beauty of the human brain is that it is taking in information from the environment and adapting to that information. But what happens when that information is traumatic? What happens when the information that a brain takes in creates a understanding of the world that predisposes folks to make decisions that are not within their intents? Well, let's look at the 6 domains that trauma can train the brain on. The first is disconnection and rejection, and this includes schemas that make it difficult to develop healthy relationships. Domain 2 is impaired autonomy and performance, which includes schemas that make it difficult to develop a strong sense of self and function as a world. Domain 3, impaired limits. Domain 4, other directness. Domain 5, over-vigilance and inhibition, which includes schemas that prioritize avoiding mistakes or avoiding failure. Now, this is important because just like our machines, if the inputs to our machines are biased, if the inputs, if the experiences that our machines are experiencing in terms of machine learning or artificial intelligence are not representative of the entire set of information that we have about an item or an object, then what that machine produces, the learning, the predicted, is also going to be biased. And our brains, just like the machine learning is based on our brains, have that same situation occurring. So let's dive in a little bit more deeply to understand what trauma can train the brain on. We looked at domain 1, abandonment and instability. Let's think about the schema that occurs when the brain is trained on these inputs. It's the perceived instability or unreliability of those available for support and connection. It involves the sense that a significant other will not be able to continue providing emotional support, connection, strength, or practical protection because they're emotionally unstable and unpredictable. Or they will abandon the patient in sense of something favorable. If you look at the bottom right here, you see rose-colored glasses, right? Well, trauma is the opposite of that. Instead of rose-colored glasses, it's trauma-colored glasses in which the world appears based on the biases that the brain has experienced through what it was raised on. Because trauma is an event or series of events that violate a developmental need or belief around the world. And a traumatic experience is one that impairs the responses of an individual to an environmental condition. Let me just say that again. A traumatic experience is one that impairs the responses of an individual to an environmental condition. A traumatic experience is something that impairs our ability to see the world as it is and to choose a response that is within our intent in terms of what we're trying to accomplish in the world. So what do we do? How do we react? What are our steps to ensure that students can react to the world in ways that are within their intent? Well, there are 3 things. We're going to talk about this through a social and emotional learning lens. Remember our analogy in the beginning. A computer machine learning algorithm is only as good as the data set that it's learning from. It's only as good as the data set that it's learning from. And our brains are the same way. They're only as adaptable as the experiences that they have. And what we take in as youth in our experiences trains our brains to be sensitive to certain things. So the first things that we need to do is that we need to provide new experiences that teach adaptive schemas. Remember, we had those 5 maladaptive schemas that informed by trauma. So the first thing we need to do is provide new experiences that teach adaptive schemas. The second thing we need to do is we need to create a structure to those experiences so that folks are aware of what they are knowing. And then lastly, we need to provide feedback to that structure. If you look at that picture on the bottom right, in Japan, when things break, when pottery breaks, it's repaired with gold because it is so important to recognize that things can be put together stronger, put back together stronger, and that what breaks us, it does not define us. So what does this have to do with social emotional learning? Well, the first thing is that we need to provide experiences that teach adaptive schemas. Now, what framework can we use to organize those experiences? The answer is a social and emotional learning framework, one that focuses on self and social awareness and management, which gives us self-awareness, social awareness, self-management, and social management. And that allows young people and folks who have experienced trauma to receive new experiences. Well, let's look at what this could look like in school. Remember, domain 1 was disconnection and rejection. And it included schemas that make it difficult to form healthy relationships. Well, what kinds of experiences do students need in order to reorganize their schemas towards adaptive outcomes? Social and emotional learning standard 4B. Social management. Students develop constructive relationships. Adults around me show me what constructive relationships look, sound, and feel like. Remember our computer analogy. What comes into the computer, the data set, the experiences that the artificial intelligence has, that is what the learning is based on. And that is what the decisions will be based on. So we need to provide adaptive schemas by doing the opposite of what it is that the trauma informed. So students develop constructive relationships. Domain 3, impaired autonomy and performance, includes schemas that make it difficult to develop a strong sense of self and function as an adult in the world. What kinds of experiences do students need? Young people need to adapt to that schema in terms of effective schemas. 1D, students have a sense of personal responsibility. Adults in my life model awareness of the responsibilities. Impaired limits, domain 3, includes schemas that affect self-control. And the ability to respect boundaries and limits, 3A, students to demonstrate an awareness of other people's roles, their emotions, and their perspectives, and adults around them demonstrate knowledge of other people's roles and care about the feelings and viewpoints of others. It is not set in stone what our brains know. And the shifting of the data set, the shifting of the experiences, the shifting of the inputs relates to the young person's ability to create new and adaptive schemas so that they're successful in solving problems and making good decisions. Well, the second piece is that we need to create a structure to those experiences. Let's look at a social and emotional concept here. 2C, students use effective choice-making and decision-making skills. And of course, the adults around me need to create opportunities for me to make good choices and good decisions and give me feedback. So we need to structure experiences so that students have an understanding of what it is that they're learning. So on the right-hand side here, you see the 8 mathematical practices. These are the things that are structured. So when students are participating in math, they're grounded in these mathematical practices that tell them why it is that they're learning the things that they're learning. And on the left-hand side, you see the allegory, you see the corollary for social and emotional practices. This is problem solving for students. Here's the guide, 5 steps. What am I feeling? What's the problem? What are solutions? What could happen? What one will I try? The clarity of those structures helps students and help young people to be aware, to be intentional about applying these concepts when they're trying to solve problems. And of course, lastly, provide feedback towards that structure. Remember, how does machine learning work? Input data, analyze, find patterns, make a prediction, store that feedback. The feedback is what helps that machine recognize whether or not that solution set is solving for what it's trying to do in the world. So we need to then provide feedback to students towards the structure. Students develop a sense of self-management, the ability to manage their needs and emotions. If students are struggling in that concept, we need to feed back towards the effective demonstration of those skills and competencies so that students can then adapt their schemas, solve problems, and move forth in the world. Now, if you want to get involved in this work, you can go to SEL Day 2022 at selday.org, and you can be involved in the work that we're doing around social emotional learning. The theme for SEL Day 2022 is finding common ground, pursuing common good. And this is going to give you an opportunity to sign up, to participate, to have your voice heard in the importance of structuring young people's lives towards building the social and emotional skills they need to be successful. So remember, we have inputs from life. The inputs from life shape what our brain expects. And just like machine learning, there are biases and inputs. And the biases that we have as young people can either help us in terms of problem solving or inhibit our problem solving. But once we have identified that a young person has challenges and have had inputs that we call trauma, then we need to teach towards social and emotional competencies, what students need to be able to do in order to successfully solve problems and move forth in life. My name is David Adams, CEO, Urban Assembly. You can find me on Twitter, dadams_SEL. You can email me at dadams@urbanassembly.org. I thank you for your time and consideration, and I'm going to turn it back to Dr. Johnson.
Thank you so much, David. I feel like I learned things as you were speaking, and I really appreciate you sharing about finding common ground and pursuing common good to structure experiences for young people's lives so that they are equipped with what they need to reach towards their development. And so as I shared in the beginning of the presentation, much like what David has talked about, is once again that childhood is not an adventure that we choose, but that it is chosen by adults, familiar and forever unknown through the experiences they create for us. And in speaking of experiences, we will now head over into the higher education arena with Dr. Karen Omi. And Karen is such a wonderful colleague and friend of mine, who is the director of the Institute for Family Violence Studies at Florida State University. And she directs the FSU Student Resilience Project. Omi's research and development team works to promote healthy individuals, families, and violence prevention across the lifespan. Dr. Omi also currently serves as the chair of the academic, the chair of the Academic Resilience Consortium. So now, Dr. Omi, the floor is yours.
Thank you, Dr. Johnson. I'm delighted to be here, and I am really in awe of the presentations that took place before mine. But I will give you my presentation, even though it will pale in comparison. I am the director of the FSU, the Florida State University Resilience Project, and chair of the Academic Resilience Consortium. And I'm here just to give you really a little overview about the discussions, things that are going on in higher education on the issues of trauma and resilience. Now, everyone already has probably much of this data in your brains. You understand the incredibly negative impact that trauma can have on the developing brain. But for so long, I think that universities didn't really see that those issues were sort of part of their mission, right? Or that those issues impacted higher ed. But that has changed. And that has changed in part because of great groups, organizations like CTIP and ACEs Too High. But you're probably familiar with the data that once young people get to, actually they basically later adolescents get to college and university, then their experiences can also impact their ability to succeed in higher education. And so I think that it's super important to understand that higher institutions of higher learning are understanding these issues. And I think that the impact of COVID has exacerbated issues of our students' mental health. It just provides a new trauma on top of perhaps previously untreated, unrecognized prior trauma, and students are suffering. There is an annual poll that goes out to university presidents across the United States. Actually, it might even be North America. And consistently for the past 5 years, university presidents have responded that students' mental health issues are in the top concerns of university administrators, and that university presidents want more resources and more understanding for students. And COVID has just brought basically shined a really bright spotlight on these issues, because the pandemic is making it even more difficult for students to access mental health care, right? So those are just some study data that I wanted to highlight. I am a researcher, and we do research on our own campus. And so I will tell you, we are no different than everybody else in the United States in that our students have been struggling. Our students do need help. Our students are worried. So we take all of the issues of trauma and all of the issues of the developmental needs of children, right? And then we add this extra layer of the pandemic. And now we're starting to see a lot of research come out about the impact of the pandemic and how disruptive it has been to students. We know that their lives have been disrupted. We know that they are extremely preoccupied with the disruption caused by the pandemic. We know that their housing and their ability to make money, right, to have income, get jobs, has been detrimentally affected. And we've also seen the health disparities. So on FSU's campus, and this is data from the early pandemic. So in the early pandemic, what we found on the FSU campus, we have a large Hispanic, Latinx population on the FSU's campus, that we quickly saw health disparities and disparities among our different demographic groups. And so we know that we need to make sure that we've got help for everybody, and help for everybody is not necessarily the same. One resource that might be helpful, because I won't be able to fit everything in this 10 minutes, is a very nice book that was just published by Paul Grave, and it's called Lessons from the Pandemic, A Trauma-Informed Approaches to College Crisis and Change. And you can get it on Amazon.com. It will tell you about the different, if there are higher ed folks who are on this call, or the guidance counselors in high schools, right, and high school faculty who are really thinking about their own students. This book will give you a nice overview of some of the really interesting and good work that universities and colleges and technical schools are doing on their campuses to try to address the issues of trauma and the issues of the pandemic. I also wanted to highlight for you the different range of things that are going on American campuses for recognizing the importance of trauma-informed care, a trauma-informed approach. And if you look, and I'm sure Jesse's going to make these slides available later on, because you won't be able to click on the links till you get the slideshow. But some really interesting things are going on campuses. And if you're not in higher ed, you may not be aware of them. And so I thought I'd just kind of highlight a few. We're talking about either campus-wide campaigns, which is what FSU has. We have our Student Resilience Project is totally online, and I'll talk about it in a second. So we've got campus-wide activities, campus-wide campaigns, and then we have certificate programs for certain students. We have, like at Columbia College in South Carolina, we have in Minnesota, we have trauma-informed resources pages, right? And it's not just for students, but also for faculty and staff, because just as we know that our students are suffering, absolutely our faculty and our staff are also suffering and have also experienced their own trauma and are also experiencing their own stressors and disruptions caused by the pandemic. But you will also see that universities are starting to develop, and I find this really thrilling, special master's degrees and special certificate programs in trauma and resilience, which I really love. There are campuses, as I mentioned, that are trying to make the entire campus trauma informed. And there are lots of, probably one of the easiest things for universities to do is to start putting trauma-informed resources on their web pages. We do see here's another certificate. We also have specialized training, which I love, for faculty and staff on trauma-informed issues, right? On the impact of trauma, on coping skills, on recognizing the impact of trauma in yourself, in your own family, in your own histories, and then acknowledging the near universality of trauma in your students. And of course, focusing on that pivot from what's wrong with you to what happened to you. And you'll see that it's even community colleges are really taking some really big steps in trying to make sure that they're providing trauma-informed resources to their entire communities. And I'm sorry that I'm going through this quickly, but I want to be respectful to get the next speaker in. And so Jesse will make these available to you, and you can click on the links and learn more about them. One thing that I wanted to note about Georgia State University is that they actually have launched a trauma-informed approach to improving dementia care for nursing homes. And that's to train nursing home staff on trauma-informed approaches, right? So using the university and the links from the university into the rest of the community to educate people about trauma-informed approaches. There's a wonderful Strong Brain Institute at East Tennessee University that promotes trauma-informed research. So I wanted to just kind of give you an overview. Things are happening. People are paying attention. People are having the conversations, and CTIP has been a huge part of that. At FSU, we have one of the first full campus campaigns on resilience that is a trauma-informed campaign. So talking to students about trauma and also about the process of healing and building resilience. And it's online 24/7. And what we really want to do is make sure that students have access to this information, because many of them who see information about trauma are realizing for the first time that their own trauma has had an impact on them, right? And who they are and where they want to go and how they want to get there. That's a little screenshot of what the online strong.fsu.edu looks like. And what we're learning is that students, first of all, are learning to break down those barriers to learning about mental health, right? So the stigma, we want to break down the stigma about mental health. And we also want to make sure, so we're a large research university. We have, I must say, we do have a lot of resources, but because we're so big, we have over 40,000 students. Lots of students kind of get lost in the shuffle. And we want to make sure that students are tied to the resources and they know where they can go to get help. And so we've done a lot of research. This is a research informed and very well published. I must say we published on every bit of this project. And that's what we're encouraging other universities to do, to actually make sure that they are publishing their research, that they're going out there and they're studying their design to make sure that it is accessible, to make sure that it is conscious of social justice issues, and that it is inclusive. And I also wanted to let you know that now you'll start to see professional certifications on trauma and resilience. And so we have a professional, it's online for adult learners, right? So it's not for students. Although we have courses at FSU for students to take on issues of trauma. We also have them in our art departments on art therapy. We have music therapy, right? Things like that. But we also have for outside learners and adult learners a professional certification in trauma and resilience. It's got 2 different levels. We've had thousands of people take it. And what we're learning is that educators across the system, from K through 12 and higher ed, as well as judges and lawyers and social workers, need access to that information. Specifically for my higher ed folks, we also have a professional certification on college student well-being, trauma, and resilience. And ARC, just a little bit about ARC. It's at academicresilience.org. If you're a higher ed person, this is a group of folks who are interested in sharing ideas, in building the research base on resilience. And there's also a conference that we're having actually it's hosted here at FSU in October. It was actually going to be earlier in the year, but we had to postpone it because of Omicron. So I think the most important thing that I wanted, click to exit. Stop sharing. Okay. Dr. Johnson, is it just me now, or can you still see my screen?
I can still see your screen.
Okay, so let me see, how can I end that? How about now? Can you still see my screen?
I can.
Hold on, let me see if I can get there.
No worries.
Whoops, just took myself off the video.
I wonder if when
Ah, I see it. Stop share. Done. Look at me. Old dog. New trick.
oh,
Thank you.
it's quite all right. And again, can you still see me and hear me?
Yes.
Okay. Thank you so much for sharing those inclusive, conscious, rooted in an expression of care, social justice focused, human-centered resources. I am thrilled for the work that you're doing and the work that you continue to do and that you're empowering others to do. I know that the next panelist is here. I see Dr. Malakovich on my screen. I was going to go ahead and go and move forward with introducing her. And Dr. Dana Malakovich serves as the statewide advisor for trauma, focused on the K-12 range and for the Pennsylvania Department of Education. Dr. Malakovich also supports Pennsylvania in moving forward as a trauma-informed state by participating on the leadership team for HEAL Pennsylvania. Dr. Malakovich is a mental health and trauma specialist, focusing now largely on strengthening schools by applying research on mental health integration in schools, trauma-informed schools, healthy learning environments, and substance use disorders for educational entities across Pennsylvania. Dr. Malakovich, the floor is yours.
Thank you, Dr. Johnson. Hi, everyone. I know that we are short on time, so I am going to rush through this, but please know that everything will be available. And as was stated, I'm with the Department of Education, so I am coming to this presentation from a state perspective at the department. And so before I move into that, I want to just take a second to say why I'm in this work, because I think our why matters and it keeps us going when we're stressed out and we want to knock it up and go to work the next day. And so prior to coming to the Department of Education, I was in the school system for over 17 years. My training is in school psychology, and I also did community mental health work. And so I have been working with children with reactive attachment disorder, significant trauma, and autism, and differentiating autism from reactive attachment disorder for a long time. And so when I got the opportunity to interview with the department, one of the things that they said was, you know, we don't want trauma-informed practices and mental health and social emotional learning and equity practices to be something we do over there. We want it to be integrated into everything we do, and that needs to be our focus moving forward. And so I thought, this is amazing because I hate asking people to do one more thing. I'm a huge proponent of relationships and integration of efforts and how we all work together. So this sounded like the perfect segue to move into the department and now the school system. And then the world kind of like went into fast forward as soon as I was hired. So I started in April of 2019. And we started as a department really thinking about how were we going to move forward with trauma-informed practices? What were we going to do in terms of stakeholder engagement and making sure that we were meeting the needs of our school communities? And right after that, a bill was introduced and quickly passed that added to the school code in Pennsylvania. And it was Act 18 of 2019. And it did all of these things that are on the screen and more. And because of our time, I'm not going to read them all, but they are accessible. And it really looked at how do you educate every single member of your school, from your school board down to individual educators to volunteers that are coming in. How do we infuse this into our induction programs for our new educators? How do we address this prior to coming into the school system and really adding information into our educational programs and really think about how we become a trauma-informed system? The other thing that the bill did when it was passed, when Act 18 was passed, it added the requirement of a model trauma-informed approach plan if you wanted to receive funding. And so the funding comes out of the Pennsylvania Commission on Crime and Delinquency, and they developed a model trauma-informed approach plan and developed guidelines. And there was a huge work group that worked on that. And this was really the start of let's think about how we do trauma-informed practices, not in silos, but start integrating work. And so we moved from this formal required plan to thinking about now what do we do in schools? And so PDE developed a trauma-informed practices in schools work group. And so I lovingly call this my roadshow. And luckily it happened right before the pandemic hit. So we were able to get to PA. We traveled throughout Pennsylvania and we really focused on stakeholder engagement. So we went and for individuals who work with me, and sometimes I don't fit into that state mold, I am extremely transparent and I don't have an ego. And so people can say whatever they want to me and I'm okay with it because when I ask for opinions, I really want to know them. And I know that people who work with me probably get tired of me talking about relationships, but that is my entire focus is relationships. So often when state agencies go out and they talk, people think they only want to hear what they want to hear. And we have really been focusing at the Department of Education on, please tell us what you actually need. Please make sure that you're saying, this is what is not working, this is what is working, and this is what we need from you. And this was a huge effort around trauma-informed practices to do that exact thing. So we asked them, what's working for you? What is happening in your school system, in your communities that is going well as it relates to trauma-informed practices? And then we talked about what challenges and barriers exist. We held these groups at a state level, and then we also did individual communities. And when we held our state level teams, we said, what are the barriers? What are the system barriers that are really impacting you that you can't put trauma-informed practices in place? And how can we help with them? And then we asked them, what do you need from us? What do you think we can do to help you? And lastly, how do we make current school initiatives more trauma-informed? Because we know that there are some mandates and we can't change that, but we do need to address how they can be more trauma-informed. We lucked out, everybody was very open. We got a lot of information and the statewide themes really came down to things that we're continuing to see and concerns that have been exacerbated by the pandemic in terms of staffing, financial needs and sustainability. And then a lot of data sharing concerns related to how do we share data between schools, how do schools and state agencies share data, and how do we coordinate all of that? And our stakeholders really talked about, we don't have the capacity in schools. Capacity is an issue. Our educators are exhausted. They're not sure how to get through their entire day. We can't ask them to do one more thing. We don't have enough mental health staff. How do we address this? and looking at the culture and climate of a school, what collaboration is occurring not only at an individual school level, but in a community with state agencies. And then addressing home life, and not home life from there's a problem with home life, but a problem with educators understanding what's happening in the home. So what is our cultural competency? Are we understanding where our students, our families are coming from, their needs, and are we addressing them in a trauma-informed manner, or are we addressing concerns in the school setting as it is a your problem and not an us thing that we want to work on and we want to partner? Policies, of course, came out, staffing and then training needs. One of the big things that came out in our individual work groups as well as our state work group is we don't have a common language. We all talk about things very differently and no one knows what anyone else is talking about, and it's confusing. So we immediately moved into the creation of what the work group called the Empowerment Through Common Language in Pennsylvania, a dictionary of terms related to trauma-informed approaches in schools. We started this right as the pandemic hit, and luckily we had already planned on doing this virtually because we had individuals from all over the state working on this document. And so it really served as the dictionary for us all to get on the same page and talk about the same things. One of the things that came out of that was our definition in Pennsylvania of what are trauma-informed care values in PA schools. And so these are the 5 that we settled on. And then we started talking about how we integrate them. As we're moving forward through all of this, we came into that we're now in the pandemic and we're starting to think about schools have shut down. What do we do to help them move forward? How do we help them with reopening? And what happened when we moved into that was we started thinking about reopening plans that didn't just address academics and when do you take attendance and how do you take attendance? But we put social and emotional wellness at the core of it. And we really focused on throughout everything that we did, how do you address social emotional wellness? How do you make equitable trauma-informed practices the base of what you do and then build everything on it? And this was our goal when we did all of our reopening plans. It morphed more into how do we address this system-wide? We changed the way we provide supports to our intermediate units in our district. We changed our whole focus to how do we create senses of belonging in Pennsylvania so that being in a school system, you feel as though you belong, whether you are a community member, a family member, a staff member, or a student. And really at the core of that is creating equitable trauma-informed practices. And so as we think about how do we move forward and what is our vision forward, one of the things we think about is breaking the cycle of trauma in school, making policies and procedures, discipline practices, communication, a focus on social safety, behavioral safety, and emotional safety, moral safety, and really thinking about how do we empower everyone in the school system to feel as though they are able to engage in practices that have a basis in relationships and not in a need to be right, in a need to have the last word, in a need to create this continual cycle of trauma, but rather a relationship with what is occurring in the moment, helping students gain skills to be able to express that, reminding adults that there are ways to express things appropriately, and identifying our own individual needs so that we're able to interact with students and families. And relationships. Our other focus is on relationships, not only with our schools, but with other state agencies. So one of these relationships comes through HEAL PA, and HEAL PA is the product of the Pennsylvania Trauma Informed Plan as Pennsylvania moves toward being a trauma-informed state where healing is the norm. This plan was put out through the Office of Advocacy and Reform, which is in the governor's office. And as we were starting our work group, the Office of Advocacy and Reform was formed. And it just so happened that it all aligned perfectly as we were working together. And we've developed cross-system collaborations and teams so that we're all working on the same thing. We have other agencies involved, as well as coalitions and grassroots efforts and universities and practitioners. And it really has evolved in Pennsylvania to a way of looking at relationships from a state level, state to community, community to schools, schools to schools, and really building networking opportunities so that no one feels like they're doing this work alone. Of course, part of the work that we do at the Department of Education is develop resources. So I have provided some of those resources that really focus on equity, trauma, and mental health, but there are a wide variety of resources available through the Department of Education. I just tried to narrow them a little bit. And my contact information will also be available. I know I went through that really quick, but I wanted to make sure that we do have time for questions for the entire panel. And of course, I'm always available if you have additional questions as you look at the slides when they are posted.
Thank you, Dana. What an extraordinary presentation. Really appreciate you sharing those resources and really walking through with all of us that are sharing this time and space together what your vision is for a trauma-informed system of care for individuals, and not just individuals, but the individuals that are connected to other individuals through relationships. And I kept hearing that theme throughout your presentation. So I just want to thank you for sharing. And I know that we have about 5 minutes before we turn over to our share your story panelists. But I wonder if what we might do is if you all would be willing to and in the meantime, what we can do is bring our panelists back. So Dr. Omi, Dr. Iruka, David Adams, that if you could come back on camera, because we do have just a little bit of time, and I did want to offer up this moment to ask a question. But really the question focuses on if there was one thing that you would like to leave and share with the panelists with, what is something that you would share? And there is no particular order, and I won't call on anyone, but I just want to encourage you all while we have these wonderful people in the room, and there's so many extraordinary resources being shared, but if there's something that you would like to share with the folks in this room that you would leave them with, what would that be?
I'll quickly start, and then I'm happy to give it over to my brilliant co-panelists. I would just say that if we're trying to focus on trauma-informed care and healing, particularly for Black communities, it is important that we really think about the culture that they had prior to being enslaved people. And that if we're trying to really fully center on healing, we have to see people not in the worst of times, but in the best of times. And so part of that is to make sure that as we really work with Black communities and children and families, that we really look beyond the historical injustices, still focus on that, but also lead into the fact of that they are part of an African nation, that could heal them and also humanize who they are beyond a slave people. And thank you for this opportunity.
Hate following up on Dr. Iruka because she's amazing. So I think that what I would say is that often we think in order to be able to build resiliency in our youth, we have to be highly trained and have certifications and have all this knowledge. And I think this comes from a professional standpoint, but also a personal standpoint. being a child who of trauma and who has a significantly high ACE score, I would say that relationships saved me. And I know that that's why I focus on relationships now. And so I would say that there isn't a need to identify what individual students in front of you have gone through, or for you to be able to say, yes, I see why they're traumatized. It's just important for you to understand who they are and where they're coming from, and to be able to build that relationship in a place that doesn't involve judgment, and just involves caring and being there for them so that you can change their brain through resiliency development.
Yes, I want to echo the statements of the two panelists before. I think for me, the number one thing I want folks to take away is that we need to organize our structures. I'm getting out of focus here. We need to organize our structures and organize our experience for young people towards a certain trajectory. And when we name that trajectory, then we can intentionally act upon that trajectory. And then we can identify things that move students away from that trajectory or move them on that trajectory. So the goal here is not to look at a young person and say that your trauma is your history, that your trauma is your destiny, but to say that these things have biased you. They've given you lenses that are hurting your problem solving. And we're going to help you. We're going to support you. We're going to create experiences that are intentional and supportive and put you on a path to growth, to healing, and supporting yourself and your community.
And I think my one takeaway would be especially for our college students, to give them hope, to normalize the struggle, right? To let them know they are, because so often people haven't talked about their trauma, that they don't realize that lots of people are carrying it around. So give them hope, give them a new perspective of who they are and where they've been. And to also make sure that we're telling our fundraisers, we're telling the people who hold the pocketbooks, that these issues are not going to go away if we just pretend they don't exist, and that we do need to put resources into these issues, because these college students, they're only college students now, and then they're in the market. Maybe many of them are already in the job market. They already have families, or they're going to be having families. And so what we need to do is emphasize healthy communities. And so not looking at individual pathologizing, as Dr. Adams said, but looking at the health of our communities.
Thank you, panelists, for your extraordinary words and wisdom to share with others here. And we were going to pivot to and transition rather to our panelists that has come with lived experience to share their story. And so we'll take this time to give the floor to Debbie Watson. But just want to again really reiterate my thanks for all of you that have shared these extraordinary words to help us stay at the top of our mind the importance of what we all know inside, right? That if you could only sense how important you are to the lives of those you meet, how important you can be to the people you may never even dream of, but there is something of yourself that you leave at every meeting with another person. And so I want to open the floor to Debbie Watson to share a little bit about their own story. There she is. The floor is yours, Debbie.
Good afternoon, everyone. I'm going to start by saying, as I look around at who is in this meeting, I am very humbled, but I thank you for welcoming me into your fold today. The first thing I want to say before I start telling my story is everything that I've only been on for about 10 minutes, but everything I hear you say, I'm here to give testimony to the fact that it's not theory, that it works. It works. So start by telling you a little bit about myself. I've been in education for 39 years. No one in my family had ever gone to college, but I started kindergarten and I thought, this is it. This is what I'm going to do for the rest of my life. I just knew. I knew that I had to be a part of that, that journey. So as an educator, I've always operated on the premise that I've always wondered, what's the why behind behavior? We all kind of slip back into that ugly traditional frame of mind from time to time that they're just making a bad choice. And sometimes that is true, but I never operated on that assumption most of the time. So I was always trying to get at the why. Teacher for 17 years, been a building administrator ever since. And so I didn't make that life altering transition though, from asking what's wrong with you to what happened to you until about 8 years ago, when an amazing lady came into my life by the name of Rebecca Lewis Pankratz. She is a nationally recognized speaker on trauma and resilience, and she's my muse and my hero. So in my previous administrative position, Rebecca came and presented about poverty and trauma to my district. That was about 8 years ago. And my school counselor and I worked with her to start a Circle of Hope chapter in our town. And so I started working very closely with some of those families, and then began to hear her message about trauma and about ACEs. So I came to Newton 6 years ago. I'm in a school of 215 students, about 60 staff members. And the summer prior to my starting, I invited all of my staff to come in 2 or 3 at a time, very informal. Just said, let's just sit down and visit. Tell me what's on your mind. What are your dreams for the school? What do you want me to know? What are the celebrations? What are the concerns? What do we need to work on? Tell me how, what your reality is. And through those conversations, there was a recurring theme about, we want kids to be able to be in the classroom learning and not be disrupting, or not be disrupting their learning, not disrupt the learning of others, not disrupt my teaching. And so I took the first year to get to know my staff and for them to get to know me and for us to trust and grow that trust. And then the beginning of the next year, we started the year by spending 2.5 days learning about, starting to have conversations about trauma and ACEs and resilience, and brought Rebecca in, did all kinds of things, did lots and lots of things, learning about the brain, learning about ACEs. I mean, it was pretty extensive journey. And then I had Rebecca come to my building once a month for that entire year. And it was just an ongoing conversation. We didn't set an agenda for the year, but we needed to learn about, what is this trauma all about, and how does it affect us, and how does it affect how we live, and how does it affect how we do, and everything. And so each month Rebecca would come and visit with my staff, and then she and I would get together and say, okay, so what's the next conversation? And we did that for a year. And then at the end of the first year, we pulled the staff and said, put yourself in one of 4 quadrants. Quadrant 1 is, man, I'm 100% on board. I totally get this. I totally buy into this. Quadrant 2 is, this sounds really good, and I think I'm buying into it, but I still have questions. Quadrant 3 is, I'm still a little resistant, but maybe willing to learn. And quadrant 4 is, this is a bunch of hooey. And so over 80% of my staff was in quadrant 1 or 2. So we decided as a staff, we're going to move forward with this journey. And we have been on this journey now for 4 years. We pulled at the end of the second year, and at the end of the third year, we pulled the staff again. Where are we at? Where do we need to adjust? So it's an ongoing conversation. It's not a destination. It is very much a journey, and that's how we live it. And then COVID hit that next year, and so we didn't really pull at the end of the year. We're just kind of in a survival mode, and some have been were very much that way last year. This year, we're very much back to recentering ourselves in where we're at with this journey. Done a lot of work. I'm not going to go through all the things that we've done as a staff, but some key pieces I think that we have done as a staff is we created our own parameters for how we live. We call it our resilience notebook. We didn't take on we didn't adopt a curriculum that someone else had created. through the learning that we had done, we put together a resource for our staff, kind of our Bible about how do we live in this space, and we continue to grow that and continue to add to that. We had 2 people in our building trained as resilience coaches, went through some pretty extensive training, and they are great resources in our building. It happens to be one of my special education interrelated teachers, and then also a facilitator for a room called our Peace Place, which I'll talk a little bit more about. We developed a building trauma team, which consists of my school psych, my school social worker, myself, and my 2 resilience coaches. And so just ongoing work that we do every day and that we continue to do. One really neat initiative in our building that I do want to talk about that I think has been very impactful has been our Peace Place. We do have calm spaces in every area in our building. I don't care if it's the cafeteria, the media center. We have areas called wet dry where small groups can go and work. My office, every space in our building has a calm space, and there and we have it's clearly defined how you use that space to regulate. But we also have a room, and so at the end of our 2nd year of our journey in becoming trauma informed, and then trauma responsive, we decided as a staff we needed a space for kids to be able to go to regulate. And so they voted to take a general education aide out of the instructional capacity and put her in the social emotional capacity, because they knew, and when kids weren't regulated, they weren't ready to learn anyway. And so we knew that we needed to invest there. We just happen to have a really under-resourced person in our building that we transitioned into that position. And that program is still going strong. It is an amazing resource in our building. So another thing that we do every day is we do a morning message every morning. And in that morning message, we always do a mindfulness activity building wide. We do it as a whole building. We always recite our school mission statement, which is, we love you and there's nothing you can do about it. You notice our school mission statement doesn't say anything about 21st century skills or technology. We love you and there's nothing you can do about it. That is our mission statement. That's how we live here. Our school mantra is, I am safe, I am loved, I have people. We recite that together every day, and that's how we live in this space. So a question that comes up often is how has COVID affected this whole journey of being trauma responsive? The biggest effect that I have noticed, the major thing that I've noticed with COVID in our building is our journey is what has allowed us to get through COVID. The support that we have in place for each other and for our students and our staff and our parents and how we live in this space is how we survived COVID. I don't know how we could have survived, how we would be surviving COVID if this wasn't how we live in this space. So that's the biggest impact COVID has had. Has not caused me to lose any staff. The only time that I have lost staff in this journey, at the end of my 2nd year, I will be quite honest, I had 3 staff members that didn't buy in 100%. They self-selected themselves out. They all decided to retire at the same time. And everyone else that we bring in, completely believes in and completely lives this. So just take a second and talk about, can we substantiate this with data? We most definitely can. A couple examples would be that over the last 4 years, our office referrals have dropped over 60%. Prior to COVID, we had cut our chronic absenteeism from about 12% to under 5%. And when we set up Peace Place initially, most of our visits were unscheduled. And now most of our visits are scheduled. It's very much a precautionary measure. And the unscheduled visits are very rare. They are the exception. I had an administrator ask me one time how I knew that our staff embraced being trauma responsive. And my my response to him was, it is how we talk to students and how we talk about our kids. That's how I knew that we truly embrace this. I want to share a story of one of our students. This is a true testimony. So I'm going to call him Benny. Benny is a fourth grader. Benny joined us as a first grader. Lots of trauma, lots of dysregulation, just really, really struggled, didn't believe in himself, no self-esteem. It just very, very sad. We've worked very, very closely with him over the last 4 years. And so let me move forward to how fourth grade started. And he honestly felt connected to adults in our building. He very much had those trusted adult relationships. Started fourth grade. Dad was in jail again. Was really struggling. We had him on universal behavior chart, and he was getting maybe 60%, if that, on a daily basis. We kind of figured out that the classroom that he was in, that there were a lot of boys who were very athletic, and Benny is not. And he was very much being left out. He wanted to be accepted, but didn't know how. And so I made the decision to switch him to another classroom where I felt like that he could connect much better with the boys that were in there. And I just knew this teacher, and I just thought, once I saw how the year started, I thought this teacher is going to be what he needs. Starting in October, we started that in October. Within 2 weeks, Benny started earning 100% on his universal behavior charts on a pretty regular basis. He is earning 100% for 4 or 5 days a week. He believes in himself. He is very positive. He uses his tools when he starts getting dysregulated and brings himself back down. Something really neat that just recently happened was that the teacher is working very explicitly. Her goal for the year is working on climate in her classroom and building community. And she shared a survey that she did with me yesterday on what the climate is like in her classroom. How do the kids perceive the teacher and their relationship? How do they perceive their school and their relationship? And then how do they feel as a student in the school, and how connected do they feel? 5 being the highest rating. Her class average was 4.2, but Benny rated himself at the top end on every single indicator on that survey. And then yesterday, he wrote a letter to the Peace-Based Facilitator talking about how listing all the people in this building that believe in him. And just the first day he got 100%, he asked me to walk him out to share it with his mom so that we could all celebrate together. So I'm gonna, I know my time, I've probably gone over. I'm just going to end by sharing this thought. We are not on this trauma responsive journey, and we don't live this way because we're educators. We do this work in this place because we are family. And it's a universal belief that family members take care of each other. So at this school, we are family, we take care of each other. That is why we're so successful. There is no magic to it. We are successful because we are family and we take care of each other every day. It's all about relationships, and that's our story.
Debbie, thank you so much to all of for sharing your story and the story of Benny and your teachers and your process. To all of our wonderful panelists, thank you for the last hour and a half of enriching conversation and dialogue. It's been excellent. We're about to head into break, but like we know, this whole workshop series is supposed to gear us toward action. And so a few links that we wanted to share to do that are 2 podcasts that exist that I am throwing into the chat now. One is called Cultivating Resilience, and the other one is the Trauma Informed Educators Network. And then I wanted to reshare PACE's Connections site, as well as where you can get involved and sign up for the National Trauma Campaign, or the Trauma Campaign broadly. As we all know, there is an effort across this country right now to take social emotional learning, trauma-informed care out of schools, for this to not be a part of the education system. That is not because it is right, but because a lot of those advocates are the loudest. And that is why the people on this call, our community, our growing community, can get involved and provide a powerful counter narrative as to why we actually do need this in our schools. And what was shared by the panelists, by the Share Your Story, by Lee as moderator, in this in the first half of this session is great reason as to why we need this in our schools. We cannot teach our children, not their minds, until we reach their hearts. We need to connect with them, build powerful relationships, especially not just because of COVID, but especially the stress and adversity that our students, our families, our teachers themselves have experienced during the pandemic. This has never been more important, and everybody has a role to play in getting involved. So again, thank you for this wonderful first session. Before we go to break, Dr. Lee Johnson did such an excellent job moderating through every call, preparing for this panel, invited us to do a reflective activity that as we get ready to go into break, I wanted to invite him back to do that with all of you who are on the line, and then we'll take a quick 10, 15-minute break before the second half healthcare panel. So Lee, I turn it over to you.
Thank you, Jesse. I don't know about you and others on the panel, and many of us joined across the US that listened to Debbie's story. I think I saw a quick comment about how could you possibly tell that story without crying? And that really resonates with me too. To hear her say, we love you and there's nothing you can do about it, that I am safe, that I am loved, that I have people that care about me. Everyone in the whole world needs other people to talk to. Everyone has feelings that need to be talked about, whether it's grandmother or grandfather, sisters, brothers, siblings, friends, or a new word that I learned, nibblings. And so I hope that you're learning to tell the people you love how you feel, and who love you how you feel. Whether you sing about it or play about it, or just say it straight and plain. So what I want to invite everyone under the sound of my voice to take the next 60 seconds or so to think about all of the people in your life who loved you into being. And I'm going to watch the time, but take just 60 seconds here, starting now. Thank you so much. I'm sure the people that came to mind for you, that it is a joy that you took time to think about them in this moment. So I'm going to turn it back over to Jesse. And again, thank you for this extraordinary opportunity to share time and space with you and with all of you that can hear my voice. Thank you so much for all you do.
Thank you, Dr. Johnson. Appreciate you as a friend and colleague in this work. We invite everybody to take about a 10-minute break. It's a little bit shorter because time got pushed back, but man, that was valuable. Breathe, do what you need to do in the next 10 minutes, take a bio break. We look forward to seeing you all shortly for our healthcare panel. And thank you again for being with us. We're still on break, just so you know, as you see your screen navigating with PowerPoints, we're just practicing for the second half of the session.
Everybody's high on consolation. Everybody's trying to tell me what is right for me. But daddy tried to bore me with a sermon. But it's plain to see that they can't comfort me. Sorry, Charlie, for the imposition. I think I got the strength to carry on. Oh, yeah. I need a drink and a quick decision. Now it's up to me who I will be. She's gone. I better learn how to face it. She's gone. I paid the devil to replace her. She's gone. She's gone. What went wrong? Get up in the morning, look in the mirror. There's a toothbrush hanging in the stand. Yeah. My face ain't looking any younger. Now I can see love taking her toll on me. She's gone. I gotta learn how to face. She's gone. I think the devil's too replace her. She's gone. What went wrong? eternity in the city. Let the carbon in monoxide choke my thoughts away. Yeah. Your pretty body's tempters of the memories. They can never be what she was to me. She's gone, she's gone. I better learn how to face it. She's gone. I think the devil to replace her. She's gone. What went wrong? She's gone. I better learn how to face it. She's gone. I can't believe she's gone. I pay the devil to replace it. She's gone. I better learn how to face it. She's gone. I can't believe she's gone. I pay the devil to replace it. She's gone. 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 She's gone.
Samantha is back in town. We're gonna party like when Tom was still with the Patriots. I can't. I just got out of rehab.
Oops. So much for using Spotify. Advertisements.
We continue to learn. That was much better music than the first one, though. We're improving, I would say.
Well, I thought
Different
I
music.
could get it through my phone.
Yeah.
It wasn't, but somebody said it was tinny, so I'm not sure.
It had me dancing.
Oh, okay.
I'm just not a good dancer, so I put myself off camera.
Oh, good. Hi, Sandra.
Who's that? Oh, is that Denny?
It's Denny, yes.
Hi, Danny.
How are you?
Thanks for your help.
Absolutely.
When, just let me ask you a question. When you do a share screen,
Mhm.
and a bar is up at the top, which makes it really hard to put it into slideshow. Is there some way not to have that happen?
I think that you can move the bar.
Yeah, you could just move it.
You can drag it to the bottom of your
Yeah,
screen.
you have to
and left
move
and
it,
right.
right? But there's no way to make it so that it automatically shows up somewhere else.
Well, you can just move it where you want it to be.
Gotcha.
That helps.
Denny, as we get back, I just want to lift up a comment in the chat that it's Friday Smooth Jams, and that can be our new brain break
There you
for these
go.
workshop sessions. I like it.
Yeah. Yeah, I've got some, it's exactly what it is, actually. So I've got some smooth jams that I listen to when I'm doing my aqua therapy.
Aqua therapy. Yeah.
Good.
Is that in a pool or a bathtub?
It's in a pool. I don't think I could put it in a pool- in a bathtub. I wouldn't get very far, would I? Yeah, it's good. I also think that the bar can
Well,
be,
Astrid thinks the bar can be completely disappeared. Good. I'm gonna try to figure out how.
can you get it back easily enough? Just so you can, unshare when the time comes. Astrid, you've been a tremendous help already electronically today. Oh, from Baltimore. That's my old haunt. This is for you, Sandra, from Ulysses Archie. Aqua therapy in a bathtub is a bubble bath with a glass of wine.
I like that.
We're totally breaking down now. This is
Yeah,
good.
we could go back and get started.
Raw emotion here. I love it. Yes, so do we have all of our speakers? It looks like we do.
Mhm.
Outstanding. Okay.
What time are people expecting us to start?
Right about now.
Okay, okay.
I think we were given until 3:15.
Yeah, so we're 5 minutes off, that's it. Not bad. But Jesse, you want to open the session or would you prefer I do?
You got it.
Right, we all ready?
Mhm.
Okay, well, welcome back, everybody. Thank you so much to those of you who are able to stick with us this afternoon. I'm just going to remind you what we said at the top of the hour or the 2 hours ago, that we will be showing the second half next Friday as well. And so you won't miss anything if you need to leave, but please do stay with us because the show just gets better and better. We have a healthcare panel today. The education panel was just absolutely extraordinary and comforting. But at the same time, I could see from the chat that it's also been provocative in terms of energizing people to do something. And that's exactly why we're here in this workshop series, is so that we can really help to organize local coalitions around reducing trauma in their systems and sectors in their own communities. And so coming together and having these networking experiences is absolutely essential to going forward. And that's why we're calling it a national movement. So the response has been exceptional and everybody has been really activated around this. And what we want to do, what we hope to accomplish through all the speakers, is to provide tools for those of you who are doing their own work in their communities, but then to connect them, to connect the dots so that we can work at similar purposes to have a larger voice for collective impact. And so with that, you know, I would like to go to the healthcare session panel. Jesse, did you want to say anything additional? Or Dan?
Just looking forward to a great second panel. We've got excellent panelists.
Yes, great. Okay, well, Sandra, take it away.
Okay.
Mhm.
Hi, everybody, and welcome. It's good to be here. Thanks for participating. I'm going to share my screen because, you know, I've got slides. So thinking about what we're going to be covering today and what we're in the middle of, I think we have to see the pandemic as a real window of opportunity. That's when something is possible to change because there is a mentality in the culture for some change. And as this quote says, don't pull down your shade, leave the windows open. And I want to, since this is healthcare we're talking about, I want us to center ourselves around what was described many years ago as the central act of caregiving, to repair to the extent possible the wounded humanity and state of inequality and vulnerability of the sick or injured person. Well, Arthur Kleinman is a physician and an anthropologist at Harvard. And he wrote, caregiving is one of the foundational moral meanings and practices in human experience everywhere. It defines human value and it resists crude reduction to counting and costing. Well, now we're in a pandemic, but it's not like our systems were healthy and in good shape before the pandemic. Our systems have been under enormous stress coming from all directions and for decades. It's not new. Sorry. There were workplace problems long before the pandemic began. And here's a short list. bullying, harassment. I mean, you've read about these, you've experienced many of them probably where you work, including the presence of people who are often quite tyrannical because they don't have models for democratic practice. Alan Francis may be a familiar person. He is a pretty famous psychiatrist who wrote that in the past 50 years of neglect and criminalization have made the US one of the worst places in the world to have a mental illness. That's a pretty sad commentary. And that's not about the people practicing mental health service delivery. That's about something profoundly wrong in our systems. But individuals experience it as burnout, and that's been called an epidemic. And when you look at the numbers, it's really pretty disturbing. Between 35 and 54% of US nurses and physicians have substantial symptoms of burnout. 45 to 60% of medical students. Now, these are people and residents. These are people just starting to work in healthcare. And for mental health practitioners, the studies go from 21% to 67%. I don't think we really know, actually. We don't have good numbers for that. Forbes explains what's causing it with three main factors: a lack of control, dysfunctional workplace dynamics, and what they call work-life imbalance. So all of that was happening before the pandemic and had been happening for a very long time. And then the pandemic hit. The pandemic has really illustrated the enormity of the conflict in values that exists, well, everywhere, but certainly in healthcare. The great failure of contemporary medicine to promote caregiving as an existential practice and a moral vision that resists reduction to the market model or the clarion call of efficiency has diminished professionals, patients, and family caregivers alike.
Sandy, you muted yourself, or you are now muted.
I don't know how that happened. Sorry, guys. I think the best way to think about burnout is to look at it as an iceberg, that on the top above the water are the individual symptoms, the things that many people on this call may be experiencing, or you have no people who are. But underneath that are the things that Forbes was talking about. Not having any control, having really dysfunctional workplace dynamics, not being able to balance your own life and your work life. And deeper than that is, I can think, a profound undervaluation of caregiving, a lack of democratic participation for people in the workplace, and a lot of structural inadequacy and exploitation that is really the source of the burnout. What that leads to is moral injury. Moral injury is present when there's been a betrayal of what's right, either by somebody else in legitimate authority or by oneself, where we feel guilty because we couldn't do what we think needs to be done in a high stakes situation. And when we're talking about healthcare and mental health care, there are no low stakes situations. And the Syracuse University Moral Injury Project describes moral injury as a deep soul wound that pierces a person's identity, sense of morality, and relationship to society. I think that is the real cause of why such a huge proportion of healthcare providers should be feeling so much burnout for a long time, not just since the pandemic. So when I'm saying I think we need to look at the pandemic as a window of opportunity, what I mean by that is we know so much more now. We know so much more now about causality because of all of the work done with the ACEs study and all of the subsequent work since the ACEs study. We know so much more. We're so much more aware in the last couple of years about the nature and extent of oppressive circumstances that many people experience. People of color, women, LGBTQ plus people, handicapped people, everybody that lives in poverty, the mentally ill, all experience oppression. And we now know a lot more about what a toll that takes. We know that democratic processes are really threatened, that they are fragile, and that around the world, not just in this country, but certainly in this country, they're threatened. And I believe in part that's because we actually don't use these practices in places like our workplaces. Something has gone wrong with our economic system. Clearly, what we found out about the extent and enormity of social inequality is kind of, for me as a physician, like a normal cell that has gotten out of control and now is cancerous. And our economic system has become malignant. And then we're in danger of destroying all life on Earth. So there's some things that are really, really, really wrong. And there's only one way that the human species has ever survived major problems, how we have evolved and gotten to where we are in the most positive way, is through collective intelligence. And that's what we're really talking about in these workshops, is how do we, and how are people experimenting with collective intelligence in all different ways. So now let's hear from, that sets the stage, I hope, for our panelists. And let's hear from, let me stop this for a minute. Let's hear from our first panelist. Let me introduce her. This is Dr. Maggie Bennington Davis. She is the Chief Medical Officer for HealthShare Oregon. HealthShare Oregon is a coordinated care organization. They coordinate physical, dental, transportation, substance abuse treatment, and mental health benefits for anyone in Oregon that's enrolled in Medicaid. Oregon is and has been really at the forefront of healthcare transformation, seeking health equity and more effective ways to engage and provide health insuring services to Medicaid members. So Maggie, take away for us.
Great. Hello. I can't seem to turn my camera on, but that's okay. You don't need to see me. I have a few slides. Can you see my slides?
Yeah, you can see them.
Cool. That's great. Okay. And sorry about my camera. I don't know what's happening, but anyway, doesn't matter. So hi, everybody. I've actually took the day off of my usual job so I could attend this whole thing, and I'm so glad I did. It's really been inspiring, and it's such a honor too to be introduced and moderated by Sandy Bloom. She changed my life decades ago in her role as mentor and guru and consultant, and continues to enrich my life. I'm also super excited to hear from the other panelists in this section. They've done amazing things in their careers, and I'm so hungry to hear their stories. And I'll start by saying, although I'm really proud of our work at HealthShare of Oregon, we have a long way to go to try to change the medical system. Medical systems are old and traditional and behemoth, and often driven by capitalism, and they're not easy to change. And so we're doing it a little tiny chips at a time, and I'm proud of that, but I don't want me to sound like we've got this wired, because we have a long way to go. So I'm a psychiatrist. I serve HealthShare as its chief medical officer. And as Sandy said, HealthShare is a coordinated care organization, which is also referred to as a CCO. And that's Oregon's latest experiment in how to improve health outcomes, healthcare, reduce disparities, and think outside the box for people enrolled in Medicaid. CCOs coordinate benefits and manage the Medicaid budget, but they also are tasked with transforming the health system. As a point of reference, HealthShare coordinates care for about 400,000 enrolled Medicaid members. And as you likely know, Medicaid is a sort of public health insurance program for people who are unemployed or underemployed, or without health insurance access through their jobs. And often they're very poor, which means as a population, people enrolled in Medicaid are often people who have experienced multi-generational poverty and all of the things that come with that, including community violence and racism and multi-generational trauma. This population in Oregon, which is about 25 to 30% of Oregonians, is also our state's most diverse group, including immigrants, people who speak languages other than English, and people of color. And as a population, our Medicaid enrollees have our highest health burden in the state and the highest health costs and the highest escalating health costs. And ironically, these are the very same people for whom our health systems historically don't work well at all. And so that's how CCOs, coordinated care organizations, came into being 10 years ago. Our then governor, a physician himself, John Kitzhaber, recognized the need for health to be considered outside of our usual silo and incorporate other parts of other systems, which I'll touch on in a moment, but really you've been hearing about all day today. So when HealthShare was first stood up in 2012, we'd received a waiver from the federal government to do things a bit outside the box. A key part of how we continue to innovate is those waivers. And we also had an $80 million grant to so-called bend the cost curve, to stop costs rising as fast as they were. So the first thing we wanted to do was understand our population. So
Maggie,
Yep.
have you gone past the first slide?
No.
Okay, all right. People were wondering, so I just want to make sure. Okay, go ahead, sorry.
Just about to. I only have a few slides.
Okay.
So we wanted to understand, but I'm about to go to the next slide. I'll do that right now, just to prove that I can. Okay, there we go. There we go. So we wanted to understand our population. And so we undertook a study looking at the 10,000 people and our Medicaid enrollees who had the highest health costs and the highest health burdens. And we were riffing a little bit off the adverse childhood experiences study, although this research design spanned a person's entire life. And it was pretty simple. The researchers simply sat with people, gave them a blank timeline from their birth to present day, and asked the now somewhat iconic question, what happened to you? And we subsequently went on to expand to thousands more of our members, but this first study is now published, and this is the citation. And I'll describe what we learned in a minute, but I want to emphasize that we've used this information in this study in essentially all of our strategic planning ever since. And when you hear about it, you'll see that at its core, it's really about ensuring that people have trauma-informed lives, really. It's a sort of a reverse of the medicalization of kind of social issues and stories. We call it the storyalization, if that's a word, of our medical systems. We're trying to get the medical systems to recognize social and emotional factors much more than they have historically. So
that's the citation. And we learned a lot, but cutting to the chase, this slide shows basically what we learned about what happened to people, more or less by phases of life. So we found, as you might expect in this Medicaid population, those adverse childhood experiences, but we also found that ACEs don't stop at age 18. They sort, in fact, of gain, they sort of gain momentum and pile up on top of each other. And that was an important visual for us, since we began to think in terms of all the places through a person's lifespan where we could provide resources or strengthen a person's experience that could interrupt that sort of snowballing phenomenon. So here, I'll take us through this slide briefly. In that 0 to 6-year-old time frame, you see that already people are simply, some people at least, are simply born into really difficult circumstances, with a third of this population suffering repeated severe abuse, almost a half experiencing neglect of some sort, and a significant percentage having the unsafe circumstances of not having access to food or even having good attachments to caregivers. And this part told us, as a CCO hoping to transform a system that results in better health, that whatever we did had to be way upstream. And you've been hearing about that all day today, but in managed healthcare, that's sort of revolutionary, because health plans generally consider kids to be super inexpensive and hardly worth mentioning, since they have relatively few health conditions or health claims. But it turns out it's sort of the beginning of a silent epidemic, and one that health systems tend to ignore until the silence is broken decades later. But moving on to the next decade of life, that 7 to 19 age group, you can see how school struggles start to erupt and affect over half of our Medicaid enrollees. And as you heard in the first part of today's workshop, education is inextricably tied with people's well-being, and it turns out with their health. We know from several other studies that kindergarten readiness, third grade reading, sixth grade attendance, high school graduation are all very highly correlated with eventually good health, leading us as a health entity to recognize that investments in kindergarten readiness, in fact, might be the single most powerful thing we can do to promote healthy Oregonians and decrease healthcare costs and the health burden in our population. In that box too, you can see the teens starting to have their own children, emphasizing the need for a 2-generation approach to our strategic planning, which has also been extremely influential in how we think about managing our Medicaid funding and benefits. And during this time of life, housing and substance use start to emerge and become constants throughout the rest of people's lives, as people, unless something happens to interrupt that snowball. That decade of one's 20s, the next box over there, then shows that ACEs don't stop. And this is where the criminal justice system begins to directly touch lives. 30%, we were stunned to think that nearly a third of our enrollees had some experience with jail. And you can see the threat of substance use and housing challenges continue into this decade of life. And here we also see the difficulties people have with jobs, which of course perpetuates that cycle of low income and poverty. And then as early as in their 30s, we see the emergence of numerous health issues, not just mental health issues, substance use issues, but physical health issues as well. And also you begin to see their terribly difficult interactions with health systems, that these systems that are supposed to be safety nets for people have thus far really failed people at every turn. So all of this information sort of showed us a trajectory, and also with another fascinating analysis that you'll see in the paper itself, demonstrated that with fairly small provisions of resources, a stable parent or caregiver, a place to live, meaningful relationships, a good experience in school, people were able to cope with these challenges and do really well with small investments. And in fact, the further upstream you go, the smaller the investment it takes for people to do well and lead healthy and successful lives. So the most important thing about this study, though, from a health plan point of view, was to give us, HealthShare, a new way to think about health systems instead of sick systems, about being upstream and proactive instead of reactive, and to understand where investments are required, which is almost universally not more money into the medical systems, but instead is an effort to ensure that people have safety and healthy social connections from birth and throughout their lives, from attachment at birth to school readiness and success in relationships, which are really just further kinds of attachments. And then also the chance to recover from trauma at any stage of their lives. So we started, I only have 2 more slides. We started here, and this is just our start. We know we have miles to go, but we started with deeply listening and trying to understand and partner with those other systems and entities that support healthy birth and early childhood, including education, including the foster child system, and then also including substance use and housing challenges that seem to be such a thread throughout people's developmental timelines. And then also this world of corrections, which is a world unto itself, trying to think about criminal justice reform as a sort of health system improvement. That's a tall order. It's really been a tough thing for us to both explore and make any progress on. But it provides but this whole thing provides sort of a roadmap for us to be able to achieve what we want to achieve, which looks more like this. This is how we envision the lives of the people we're charged with improving, how the health system might see its mission in a new way. And it would be really fun to tell you about the specific programs and partnerships and initiatives we've tried using this slide as our prompt, some with great success and some with resounding failure in response to this scaffolding, including how to heal our healers, as Sandy touched on in her introduction. But I'm going to end here. Thank you for listening. I'm super excited to listen to the other panelists, and I'm really glad to be with you today. And so I'm going to figure out how to stop sharing my slides, which is always one of the hard parts. But you can start talking, Sandy, because
okay. Well, May, one of the questions that somebody asked was whether this data has been published.
Yes, that was in the second slide.
Okay.
And Jesse can get those out to people. But yeah, the second slide was the citation.
Okay, terrific. Thank you, Maggie. That was, I just think that study that you did is so important because it sums up pretty much everything that needs to change. and that it's pretty basic. It's pretty simple. Just take care of children and young families. Yeah. All right. Our next panelist is Dr. Angela Diaz. Angela is the Dean of Global Health, Social Justice, and Human Rights of the Jean C. and James W. Crystal Professor in the Department of Pediatrics and Professor in the Departments of Global Health and Health Systems Design and Environmental Medicine and Public Health, all at the Icahn School of Medicine at Mount Sinai in New York. She's also director of the Mount Sinai Adolescent Health Center, and I believe that Dr. Diaz is going to really fill us in about that exciting work that she is doing.
Thank you, Sandy. It says that I cannot turn my video because the host has stopped it. So can someone turn on my video? Allow me to turn it on, please. Thank you.
Yeah, here we go. Good.
So I would like to share my setup with my PowerPoint. Can you see it?
We can see your Outlook calendar.
Can you see it now?
Yeah, right, yes.
Okay, so good. I'm very excited to be here. And you know, this is a topic that I really had dedicated my life to, working with youth. And I will share with you, as Sandy said, about the work that I have been doing at the Mount Sinai Adolescent Health Center. And I would like to start by, this is a map of New York City. The X is where our program is in the Upper East Side. Every black dot are patients that come to us. So this shows you that young people come from all over the city, all over the state, and they also come from other states. So we have a very broad audience. They come from all over the place. At present, we have 38,000 young people, and we serve more than 12,000 ages 10 to 26. That's the age that we serve. And I want to share with you what we are finding in terms of maltreatment and trauma. Almost all the young people that come to us have a history of trauma, even though this is supposed to be a regular traditional health clinic for young people. And this particular study that I did, 60% had a history of childhood maltreatment, including abuse and neglect, and 37% had physical and or sexual abuse. This is just to give you a sense of the population. This is a different study that I did, randomized study, and here 54% had either physical and or sexual abuse. And you can see sexual abuse was about 25% of the population. And these are, male and female, all the people. This is a study that I did with females. These are my own patients. They were here to see me for routine healthcare, physical exam, and 23% had a history of abuse. And most of the abuse was from family members, and 66% was actually by blood-related family members consisting of incest. So very, very high numbers. And the majority of the sexual abuse began in the first decade of life. Very, very early. And this is to give you a sense of the age, at least in the population, this particular study began as early as 3 years of age. As I said, first decade of life, mean age 8.8. The perpetrators went from adolescents to the aged. But when I say adolescents, it's not two adolescents making out, because to me, that's typical adolescent behavior. This is, let's say, a 16-year-old having sex with a 4-year-old that was clearly abused. And the mean age of the perpetrator was 32 years of age. I mentioned to you the survivor was 8.8, perpetrator 32. Just imagine the imbalance in terms of the age, development, and power. In addition, that these are the people who are supposed to be loving and taking care of these kids. When you look at who was abusing these kids, the number one person in this particular group was biological fathers. And when you combine biological fathers with other father figures like stepfathers, mother, boyfriend, they made up 53% of the abusers. But basically every family member, including mothers, were abusers. 67 of the youth had one abuser, but usually over time, and 33 of them have multiple abusers, usually sequentially. So the 100 girls had 165 abusers. In terms of the duration of the abuse, 21 were abused once, and to me, once is once too many. But most of them were abused for months and years, sometimes over 10 years. And remember, I'm seeing them as young people, in adolescence and young adulthood. And in terms of the frequency, also some of them were abused multiple times per week, sometimes even daily. So ask yourself again, I'm seeing them as youth. Some of them have been abused for 10 years, more than 10 years. Some of them have been abused multiple times per week, sometimes daily. So when do they have the time to go through the normal growth and development that children and adolescents are supposed to go through? This is just comparing, these are all my patients. The one that told me they had been sexually abused and the one that said they had not been sexually abused. They may have had other type of abuse, but this is about sexual abuse. So you see that the ones who were abused were more likely to have a history of running away. So when you see a kid running away, don't just say it's a teenager running away, that's what they do. No, find out, what are they running away from? Just look into it. It may be just that they want to go to the friend's house, but it may be much more than that. They also have a lower sense of self, lower self-esteem in a number of areas compared to the rest of the population that I work with, that is also quite challenging in many, many ways. They have less trust, poor communication, and a sense of alienation and distance from their mothers. And they also were much more likely to be depressed, with 59% having moderate to severe depressive symptoms. 85% had suicidal ideation, with 43% actually having had attempted suicide. And the way I mentioned to you, this was females, this particular study. And the number one way that they attempted suicide was by taking pills, which is usually how the young people, the females, try to kill themselves. But you see the different ways that they try, because it's so painful, the abuse. And this just to remind us that when you see one abuse, look for others. 100% of these youth were sexually abused, but also 68% were also physically abused, 59% emotionally abused, and 28% had had other sexual trauma, like stranger rape, for example. Although 83 that had had relationships, because I'm seeing them as youth, so some of them had had their own relationship. Out of the 83, 25 or 30% were already in abusive relationships. So we also need to try to help people heal and break the cycle of that. The way that I identify the young people with a history of abuse, this is about sexual abuse, is I will say to them, has anyone ever touched your body when you didn't want them to? Or has anyone ever asked you to touch them in a sexual way when you didn't want them to? And I say your breast, your vagina, your penis, your buttocks, your anus. And I also say, if so, I say, was it your father, your mother, your grandparents, whoever? And I do this because they usually do not walk in telling me my father is having sex with me. Also, I want them to know that I know these things happen. And if it's something like that happened to them, they can feel comfortable sharing with me because I will be able to handle it. They can always decide not to share, but they have the option. I also am very interested in sex trafficking of youth. So I asked these youth, the same, I asked them also, has anyone ever pressured you to have sex because they gave you food or a place to stay or money or drugs? Or have you needed to exchange sex for those things? Or have you been in the life? Sometimes that's how the youth refer to being prostituted, to being exploited sexually. And this is just to give you a sense of this group of kids that had been had to exchange sex for these other things. 41, just to give it some of the characteristics, most of them live in New York City because those are the kids that we are in New York City. 41% of the males had had sex with men. 37%, 32% of the females had had sex with women. Also, 37% had had sex-related transmitted infections. 20% had been in foster care. 19% were young mothers, teen mothers. 16% had come from outside the US. And 8% identify as transgender. And 4% were HIV positive. And the work that we do is Trauma Informed and Healing Center. And I feel silly talking about trauma in front of Sandy, who really created that whole field. But everything we do is trauma informed, trauma responsive, and some of the interventions are very trauma specific. But I also think about them as healing. What we do is helping the young people heal. And also we want to help them foster resilience. And by definition, resilience is that something really bad happened to you, and that because of the protective factor and environment and internal and external internal assets, external resources, you are able to have a more positive adaptation than despite of what the really bad thing that happened, the injury that you suffer. And I think that our program sort of serves as a protective factor. What I mean by that is when the young people come to the program, the staff are really supportive. They really develop connection. So the young people come to this environment that people really love and care for them and trust and treat them well. Also the staff in the second bullet help them self-regulate. We do that type of work with them and try to help them have better sense of self, social competency, and those things. And I just think that different places, whether it's school, the first panel before was about school, clinics, different places can really serve a function to be a place that young people feel safe and connected to help really promote resilience. And this is the actual model that I'm going to spend the rest of the time talking about. So it's called the Mount Sinai Adolescent Health Center. It's an integrated model. And I'm going to start with the clinical services. The clinical services are integrated medical, sexual and reproductive health, health education, dental, optical, behavioral, and mental health. I often say from head to toes, from dental to mental. And you can see how robust the different programs are. We do a lot of different things in these areas. We also have many specialized services for specific population that we know will need more. And that, that includes the young people with the trauma, the human traffic, young people with substance abuse, also young people who are HIV positive, gay, lesbian, transgender youth, the pregnant teen, the parenting youth. And we also have legal services to help, because sometimes you need that piece also to help the young people do well. We have a big center in Manhattan in the Upper East Side, and we also have full-time clinics inside 6 high school buildings. And through those we serve 24 high school and middle school, again, with the integrated program. We integrate the clinical services with community. We do a lot of work in the community, and we can get into that when we have question and answer if you are interested. We integrate the research within the clinical practice. So everything is sort of integrated. And our program is about really helping young people reach the promise of adolescence and realizing opportunity for all. And it's a program that we are here 53 years, since 1968. And it's a program that we have always been about equity. And we have a frame that is about racial, social, economic, and sexual and reproductive justice. So we really just do not want to do physicals. We really want to help young people really achieve what they have the right to achieve and their full potential that we have been chipping away from the moment they, I think, their mother is pregnant to whatever age. And now I want to talk a little bit about, I'm also very interested in advocacy and helping shape policy on behalf of young people. And then in mental health, I want to talk a little bit about that. So, mental health, we have everything that we do is youth specific, expression center. So we have a mental health program that young people come for intake and they get assigned a therapist that they have to come, let's say, every Tuesday at 2 p.m. Some youth are not able to do that. There's too structured for them. If you are homeless, if you are being trafficked, that just is not going to work. The traffic kids cannot say to their trafficker, oh, I have my 2 p.m. appointment at Mount Sinai. So what we did was that we created about 25 years ago, in addition to the more traditional, a mental health program where the mental health staff, and the mental health staff includes social workers who are psychotherapists, psychologists, child and adolescent psychiatrists, art therapists, that we actually have some of them with flexible schedule and opening in their schedule, working right next to the medical staff. So I'm trained medically. So if I see my youth and I see they can benefit right then and there, I connect them to a mental health person and they can get a dose of mental health. And we also have mental health within the school-based clinics. The modality that we use include trauma-focused cognitive behavioral therapy, dialectical behavioral therapy or DBT, and eye movement desensitization and reprocessing, the EMDR. And we also provide the therapy individually, in group, family therapy, as I mentioned, and art therapy. And to close, we do mind-body work, so the young people do yoga. We do healing through the arts, through photography, and the whole clinic is has their art all over, and we do open gallery for them so that they get positive input, because many of these kids, most of them are Black and brown, so they just get negativity. So we want them to really be the center of positive energy, and then it's their place, everything is around. And we also, they dance, so they're able to dance here. And we do academic support, because as the last panel said, to me, education is my #1 outcome, even though this is a health clinic, because I know if the kids are not educated and doing well in school, they get trapped in the cycle of poverty. So we help them with tutoring, SAT prep, college entrance things. And also we do social emotional services, like social services. So that's who we are. I look forward to the question and answer, and thank you for the opportunity.
Thank you so much. That was such a beautiful example of what can be done after Maggie's presentation of what it looks across the lifespan. Then that take on adolescence, and really you're doing tertiary prevention, but you're also doing primary prevention, because they're the next generation, right?
Exactly.
So it's one. I wish we could just take all of that and put it everywhere in the country.
And I just want to say quickly, everything is at no cost to the young people. We don't exchange money. We pay for their labs, their medication, and give them MetroCard for transportation. So we try to have no barriers for them, so everyone that needs can come.
It's wonderful. Thank you.
Sure.
Okay, next up is Stan Sonil. Stan is an assistant professor of internal medicine, hi Stan, and pediatrics at Emory University School of Medicine. He is also associate program director for the Emory J. Willis Hurst Internal Medicine Residency Program at Grady Health System. His research interests include ACEs, trauma-informed care, advancing health equity, and addressing the social determinants of health in clinical care settings. And he's passionate about that, I know, from meeting Stan. So Stan, take it away.
Thank you so much, Sandy. Good afternoon, everybody. It is a real honor to be here and have this opportunity to share and just participate in this discussion with some of my professional heroes and role models. I am delighted to share with you some thoughts from a clinician's perspective on how to cultivate this movement. What can we do from a pediatric primary care perspective to push for resilience-focused relational health, again, in the clinical context. I thought about preparing some slides, but I thought, typically that's what I do. But in this, I think for this panel, I just wanted to just, I guess, speak from the heart and talk in terms of in a more narrative pattern or fashion, I guess. It was about 7 years ago in 2015 when I first heard about the topic of ACEs and resilience and trauma-informed care. I was actually in my very last year of residency training. So I wasn't even in med school, but I was in my 4th year of residency when I serendipitously attended a lecture by a child abuse specialist in Chicago by the name of Dr. Marjorie Fujara. And I'm intentional about saying her name today because this lecture that she gave me, or that she gave to us on ACEs and resilience, which she poured her heart into, it changed the trajectory of my career. And Dr. Fujara sadly passed away this past October. And so I just wanted to honor her on the record for her impact on my life. Now, as she talked through the ACE study and was explaining about toxic stress and the neurobiology and resilience, basically the science diversity, my jaw was on the ground. I sat there stunned. And then I was angry. And then I felt frustration. How could I have gone through 4 years of medical school and almost 4 years of residency, never to have heard about this topic that was so fundamental to understanding the factors that are so important to shaping our health and well-being. At the time, I had this sort of sinking feeling that the practice of medicine and healthcare was more about disease management as opposed to healing or helping people flourish and thrive. And that's what I came into this career for. And so I, like many others in this call, I'm sure we came into this career with the express goal of learning how to help people heal and flourish. And so when Dr. Fujara gave her talk that day, I ate it up. And I guess I didn't realize how hungry I had been. So one of our priorities in healthcare, I firmly believe, has to be in reforming the way that we educate health professional students. This is not restricted to those in medical school or nursing school, but I'm also talking about pharmacists and physical therapists and phlebotomists and our medical assistants. Everybody who is patient facing needs to understand this science, needs to understand the key concepts around trauma-informed care. This is foundational knowledge that we're talking about. It should not be considered elective material or extra credit. It's foundational knowledge that needs to be taught in foundational context, foundational settings. And so I believe it's critical that students learn this early on in their training so that they have time to learn and practice how to integrate it into their care and patient care at the bedside. And so to this end, a few years ago, I helped start a student-led group in Georgia called STAR, which stands for Student Task Force on ACEs and Resilience. And I love this group, y'all. STAR is this is a multidisciplinary group and a multi-institutional group across the state of Georgia. And our purpose is to bring students together. It's a student-led group, and our purpose is to bring all of these learners together around a shared goal, collective goal, around educating students and equipping them to integrate these trauma-informed principles into their care or practice. And yeah, one of the things I really love about STAR is that it's not even limited to learners or students from health professional programs. We've had students from law school and public policy participate as well. And so it really is, I think, a counter narrative to the organization of our health system today in terms of how it's so siloed. We have public health students who are rubbing shoulders with medical students who are rubbing shoulders with public policy students. And we're having dialogue about what can we do from our vantage point to bring this kind of training into our health professional training settings. And so to date, we have hosted 3 annual trauma-informed training conferences. We've connected students across schools. Again, this is specific to the state of Georgia. And shout out to Resilient Georgia, which is a nonprofit who has played a huge role in funding us and in giving us a lot of support. And we've also engaged in different advocacy efforts at the state level, state government level, and certainly have advocated for curriculum reform. And so this group is, I'm really passionate about the work they're doing. And again, I just want to point out that they're student-led. So I think there's a point to be made that when you allow students, when you empower students and you facilitate them to meet together, they will run, they are so passionate, they will run with it, and their energy really inspires me every year to this day. So additionally, 2 of my mentors from Chicago, I think they're on this call actually, Dr. Audrey Stillerman and Pat Rush, they have been involved with developing trauma-informed medical competencies for medical students in conjunction with the AAMC. And I think this is going to be published in the next few weeks, so keep a lookout for that. But I point this out because having competencies is huge. It will allow medical educators like myself to go to our leadership and really advocate for formalizing trauma-informed training in the medical school or residency setting. And so I'm really pushing, I'm really hoping that we can get beyond the one-off lectures, the one-off didactics, the 101 on the trauma-informed care one-on-one, and really really jump in the water and move towards developing these interpersonal competencies so we can put this theory into practice at the bedside. The next thing I want to share about is one initiative that I've been working on over the past year and a half. And to set this up, what I'll say is over the past several years, I think broadly speaking, there's been a lot of dialogue around how can pediatricians get involved in response to what we've learned about ACEs. And so first, I think the field is moving away from this hyper focus on ACEs and more towards understanding how these positive social and environmental contexts, how those can promote flourishing even in the face of future trauma, adversity, or ACEs. Second, after residency, I made one of the best decisions of my life, and I did a fellowship on preventive medicine and public health at Cook County Hospital in Chicago. And during this time, one thing I realized was how much prevention could actually represent an opportunity to advance health equity. And I'm talking about primary prevention, not secondary prevention in terms of screening. I am absolutely sold out on the value of primary prevention. However, by and large, our health system doesn't seem to consider it as high of a priority as much as probably many of us would like it to be. Now, I practice pediatric primary care in a public safety net system in Atlanta. Most of our patients come from communities that have been historically oppressed, neglected, underserved. And again, in an effort to move away from the trauma or ACE screening, which we know is controversial and it's also being studied in many places, our group, we wanted to focus instead on how to promote this idea called relational health, secure attachment between caregiver and child. And we wanted to explore how can we talk about this with families in a way that's accessible, that's not condescending, that's more partnering and informative. And so just to kind of level set, the way that I kind of think about relational health is it's a state or sense of connectedness, safety and stability that a child has with his or her caregiver. We know that children who are raised in these safe, stable, nurturing environments, they have greater capacities for resilience. And even in the face of future ACEs, they are more likely to overcome challenges and succeed. And I believe that primary care pediatrics represents an untapped, a wonderful opportunity to promote relational health. You know, in the first 2 years of a child's life, a pediatrician might see that child 9 or 10 times. So that's a lot of different touch points that we have in a longitudinal perspective manner that we can actually leverage to have productive conversations that support healthy attachment, that support parents in that effort as well. The problem is we are still not training our future pediatricians on how to discuss this, certainly, or much less learn about various evidence-based, culturally humble parenting strategies that focus on healthy and secure attachment. So we started with the question, how can we promote early relational health as primary prevention? And in response, we came up with the idea to develop a poster that would be put up in exam rooms. And this poster would serve two purposes. So one, it would function as a standalone infographic that a caregiver could read and learn about relational health. And two, it would be a tool that a provider could use as a launching pad to foster dialogue around relational health. And so in developing the poster, we came up with an analogy that we hoped would be accessible and memorable. So let me share it here. I'll walk us through it. Okay. So hopefully we can see that. So here's our poster. And before we went live with this, we had a couple training sessions where we introduced the topic of relational health, trauma-informed care. We also had some mock interview sessions where we had residents practice interviewing each other, going through this poster. And I'll say that we also had the help of a friend who's a graphic designer, and she came up with the idea of Dr. Fox, the Dr. Fox character you see here. So on the left, just real quick, you see that we've included a non-exhaustive list of ACEs and PACEs, or positive childhood experiences. And we use this analogy of a basket trying to fly to represent a person thriving or flourishing. And positive experiences are like the balloons, which can lift us up. And the idea is the more balloons you add, the more lift it gives the basket. ACEs, however, are represented by the rocks that can be added to the basket that can weigh it down or make it harder to fly in the air. Some rocks can be cut off. So for example, a caregiver or a family member, if they have a substance use problem and they receive help for that, that could be an example of a rock being cut off, which could theoretically help the basket fly higher. Lastly, on the far right is the weather. Sometimes the weather is great, which allows for the basket to fly easily, but sometimes the weather is not great. It can be bad and it can pop balloons. And so the reason that we thought it was important to sort of make this distinction about what we can control, what we can't control, is to open up a conversation around, hey, are there any social needs that our clinic can assist with? We have social workers, we have case managers, we have behavioral health, and these are resources that we'd love to offer if you would think it'd be beneficial. And this past fall, we conducted a small pilot study with our first and second year residents in a pre and post study design. And we have some very preliminary data, but what I'll say is that our pre and post comparisons across the board showed increases in the frequency of conversations around relational health, as well as, and this is what makes me happy, resident confidence went from rarely to often in having these kinds of conversations. So as I wrap up, from what we learned in this, what we learned from this project is that it's feasible to have these conversations on relational health. Providing trainings and a tool for providers to use can be one way to facilitate this conversation. So in summary, the 3 things I will submit to this audience are: 1, if we want to build a national movement to prevent trauma and foster resilience, we have to reform medical education. It has to include as core material the science of adversity. It's not extra credit. It can't be an elective course. It's foundational, it's fundamental, it's core. I'm tired of the one-off didactics. We need more experiential learning opportunities like the trauma-informed physical exam and interview. Secondly, students are our next generation of leaders, and they are eager to get involved. When they're organized and empowered, they can accomplish amazing things, and the STAR group is a testament to that. And then third, in pediatrics, I really believe we have an opportunity to focus on primary prevention through promotion of early relational health, and we have to train our future child providers how to do this. In closing, let me say that Sir William Osler, one of the founders of modern medical education, he once said, and I'm paraphrasing, that in medical training, the education of the heart has to keep pace with the education of the head. And so when we teach our health professional learners about the science of adversity and trauma-informed care, when they see how this can anchor them and ground them to a perspective of empathy and compassion, and when we equip them with the tools and skills to translate the science into practice, we heed the words of Sir William Osler, and we educate the heart towards humanism. And to me, there's no greater gift we can impart to future generations of health professionals. Thank you so much.
Thank you, Stan. That is so important. You know, many years ago in the early 90s, through the lens of domestic violence, we offered trauma training to the five medical schools in Philadelphia. So those students, and they were first and second year students, and they came on a Saturday morning. It was a sellout crowd, and because I agree, they want to know. They want to know this stuff, and it's only what the resistance is. It's hard to understand. So thank you, Stan. Well done. Okay, let's get to our final panelist, Laura Jana. Laura, hi, Laura. Laura is an Omaha-based pediatrician and a social entrepreneur, and an award-winning author. She has authored over 30 either children or parenting books. She currently holds a faculty appointment at Penn State at the Edna Bennett Pierce Prevention Research Center. And one of many interesting things about Laura is that she worked early in her career with Dr. Spock. And not the one from Star Trek, the one, Benjamin Spock. And she went on to co-found one of the first online and parenting websites in 1999, way ahead of the curve, and subsequently spent 20 plus years working with parents, educators, the media, academia, government organization, nonprofits, and corporations to help people understand all this work, promote healthy lifestyles, and address the needs of children, families, and communities. So I will turn it over to Laura, and you can bring it home.
Hey, well, thank you very much. And I have to say, I'm probably as enthused as everybody I see in the chat about all the speakers that I get to be panelists with, because what I think I kind of do in my current professional role is absorb all the words of wisdom that we've all just heard, and actually not even just from the healthcare panel, but from the education discussion. And I rack my brain as to how to get people to pay attention to this incredible work and the research and what we know, to Stan's point about putting the heart back in medicine, in education, about making sure kids are school ready, not in the sense of just knowing their ABCs and 1, 2, 3s, but social, emotional, and relational kind of aspects of learning as well. So with that, what I think I'm going to do is give you a bit of I'm not going to use slides. And I think I'm just going to give you a bit of a sense of what I've been doing over the last, I would say, 6 or 7 years, pretty focused in terms of getting out and reaching as many audiences as I can. And what I've done is sort of fine-tuned the way that I describe a lot of the work that you've heard about today. And I hope you'll kind of hear how I do that as I move along in this sort of brief presentation. The first thing I'll say, what I often tell people, is that by background, when people say, what do you do? Who are you? I say, I'm a pediatrician by training. And given that some of the work I do is around soft versus hard skills and social emotional skill development, I say, and I was hard sciences. I was cellular molecular biology, would have been a math major, but I didn't know what I'd do with it. I worked in neuroscience labs and thought I was going to be a neurosurgeon. Except I loved kids and I love people, in particular when they're awake as opposed to asleep. And so I ended up becoming a pediatrician, which some people thought was a foregone conclusion. Both my parents, very academic medicine. I always say I had the Harvard, Hopkins trained pediatrician parents. And in fact, not just academic medicine. I always tell people in my head, I'm very academic. On paper, not so much. But it's, it's not just medicine, it was also public health. And the easiest way I can say is I was born and raised public health, as in my mother was not only a pediatric infectious disease specialist, but she ended up dean of one of the top public health schools in the country, and then ended up running the US AIDS Commission at the outset of the AIDS epidemic. So my dinner table conversation was how to put AIDS in the context of everything else we knew. It wasn't just, again, the hard sciences of find a vaccine, but what about prison overcrowding and tuberculosis spread and poverty and all sorts of other social issues that had a huge impact on how we did or didn't handle the AIDS epidemic. So I pretty early in my career jumped off what I would thought was my straight and narrow traditional academic medicine path, in part because I did work, as you heard, as Sandy mentioned, worked with Dr. Benjamin Spock when I was still a medical student and then a resident. And I ended up working with him on the last edition of Baby and Child Care before he passed away. And then I co-founded the Dr. Spock company with his widow. And what I saw then was an opportunity to take all of his work and his, as people would say, name recognition, but use the background evidence that we had in pediatrics. And at the time, I'd already started doing some work with the American Academy of Pediatrics, and then subsequently became a spokesperson for the AAP. And my vision was, how do you wed really good evidence-based academic research and what we know and translate it into practical, tangible, usable, culturally relevant and sensitive of messages for that is where I sort of jumped up. And then things I've learned to say, first of all, and again, this is going to kind of play into what I want to just give you a sense of how to convey these messages, is that when I get asked, for example, if I miss being a pediatrician, which I get asked all the time since I'm not in clinical practice anymore, I always tell people, I believe I still am one. I just admittedly have a broad definition of pediatrics that I would suggest to people we would be better off adopting. And you just heard such a great example of that from Stan in terms of what the work we need to do in the traditional kind of view of the healthcare system of pediatrics to expand it to include these things we know about not just healing and trauma-informed care, but flourishing and thriving and all those sorts of things. With respect to public health, I just tell people I too do public health, not as much in the traditional formal sense of it, but I say I do new age public health, how to get the message out to the public. All right, so the reason I share that is because in some ways, in lots of ways, and in lots of instances, I somewhat feel like an imposter in almost every conversation I'm in, because I cross a lot of sectors. I end up following people like Sandy and Maggie and Angela and Stan, who go really deep in the area. Whereas what I've learned to say is I am a connector of dots, which I think you heard Denny mention right at the outset, is that's the challenge we face, especially with this kind of work. And I'm a glorified translator. All right, so I strongly believe that anyone who's committed to informed policy and practice, whether within the healthcare system. Yeah.
May I interrupt you? I think that you're rubbing papers or clothing or something on the mic, and it's creating a lot of static. I think that's what it is. I'm so sorry to interrupt you.
Maybe it's my sleeve or something. I'll hold really still while I'm talking.
Oh, thank you. So sorry.
I talk with my hands. It gets people's attention more. Thanks for saying something though, Denny. I appreciate it. So anyways, I think being able to articulate these messages, and I'm going to kind of go through this relatively quickly because I don't want us to run over. But knowing what I know about trauma, ACEs, social emotional learning, what impacts life trajectories, all the things we've been talking about today, I chose to focus particularly on making clear how and why early childhood really is everyone's business. And I choose those words carefully. And I've done that by writing books, giving keynotes, engaging with children, parents, community organizations, educators, the media, economists, business makers, and basically anyone who will listen. And because of this focus, or lack of focus, because it's pretty broad, I'm often introduced as an early childhood person. And to that, for anyone who kind of deals in this space, I suggest that the really good answer to that one is, well, I am, but I'm not just an early childhood person, I'm a root cause person. And what we're all dealing with is trying to get to the root cause of things, which includes prevention. So with all of that in mind, like I said, I've done all sorts of things, including, and I won't go into some of the details of what I've presented in easily accessible things, but I've given a couple TED Talks, which are almost TED Talks in disguise. So if you're looking for the words trauma-informed care and adverse childhood experiences and things, you might not find them. But the first I gave in Omaha about 7 years ago was called 5 Connections That Will Change Children's Lives. And in the spirit of connecting dots, I did everything from 5 connections, connecting neurons in the developing brain, connecting what we know now with what we want, what we do now with what we want later, reconnecting health and education, right? And connecting to the world our children will live in, like trying to set them up. And that gets to this idea of school readiness and things, but extending well beyond that into jobs and workforce and all sorts of things. Now, my interest in ACEs first started, like Stan, I had somebody fairly influential impact me and really get my attention. It's not that I'd never heard about ACEs before, but when I went to the National AAP conference and I heard it was a relatively short presentation by Neil Halfon, who some of you may know, who's done a lot of work in life trajectories for children and improving life trajectories. He presented the ACEs study in such a way that it really caught my attention. Like Stan said, jaw hit the floor, went, how do we not pay attention to this? You know, we measure blood pressure and blood sugar and, you know, protein in the urine and things, but the predictive value of ACEs. And I realize now that we've moved well beyond that. But at the time I thought, if only people knew how important this work was, we'd be spending a lot more time paying attention to it. So given that this is the healthcare discussion group, what I thought I'd do is share what I then went on to kind of conceptually come up with as a framework to kind of help people understand how we've moved into this different realm and pull them also into the sort of positive strengths-based approach, not just the deficit model that people have a tendency to go towards. And that's what I call the Health 3.0 framework, which I will say right up front, I did not create in concept. And in fact, it was a paper that Neil Halfon and others put together as a discussion paper for the National Academy of Medicine at a meeting that I had the opportunity to attend. And in their case, they were talking about healthcare financing very specifically. So I would say it's a paper that might be buried enough that a lot of people wouldn't find it. But here's the general concept for you is Health 1.0, first half of last century. Very broad generalizations I'm going to give you because I usually have a very short amount of time to get people's attention. Acute disease, acute illness, right? Something breaks, we fix it. Healthcare system did that, infectious disease, cardiology, all these areas. Not all the way through, but that's first part, Health 1.0. Health 2.0, chronic disease. And that was in the era that I trained in, right? Where it was, I actually felt and saw in the 80s and 90s, this massive shifting of the healthcare system and trying to figure out everything from where do people go and what do we do with them if we only had, you were either at home, you were admitted to the hospital, you were in the intensive care unit. That was about it. And so what we saw was this expansion. I would say, think of Health 1.0 as a house, just 4 walls with a roof, right? Health 2.0, we had to expand those walls and make it a little bit bigger to try to fit in all these extra sort of, health services to accommodate people who lived longer, lived with longer chronic illnesses. We saw all sorts of things like that. So that's Health 2.0. And then Health 3.0, which gets right to the heart of what we're talking about, which is wellness and prevention. And when I get people there, lots of people kind of nod and they can feel it. Technically started in about the 90s, but really now people feel that we're moving there. But I want you to picture those 2 houses, the one, a bigger one outside of it, we expanded. And now think of this big amorphous blob outside those 2 depictions of 4 walls. And what we're seeing is this move into this outside the 4 traditional walls of the healthcare system, where I like to use the statistics often cited now about how it's estimated that 80% of traditional health outcomes are determined by things outside of the traditional healthcare system. All right. And in wellness and prevention, what we see is, first of all, this is where you get things like my professional career, where people can't figure out whether I deal in the world of education or health, because it's the same thing, talking about developmental screening, talking about social determinants of health, talking about all these things that all of a sudden we're unbundling all our professional sectors and our silos and everything that we kind of distilled and all focused in our narrow areas and saying we need to look at whole child, whole family, whole community, the relationship and the connectedness. So that wellness and prevention shift is a big one. And all I have to do then to get people to pay attention is say 2 inherent things happen when you shift to wellness and prevention. 1, you shift outside the 4 traditional walls of the healthcare system. And 2, you go young, right? Because if you're going for prevention, and that's where I deal in the world of prevention with the idea and the awareness that selling prevention is a tough thing to sell, right? Because our brains are wired for short term. And one of my favorite phrases that today's media, for example, is competing for amygdala mind share, for those who study the brain science of this, which is what's immediately in our faces threatening us will get our attention, whereas something major or really important, but long-term off in the distance is a much harder battle. And so that's where I focus in terms of that prevention. And as my colleague at Penn State often says, Meg Small, clearly, it's very clear way of thinking of it. The problem with prevention is that if you do your job well, nothing happens. Right? I mean, you could argue flourishing happens and things, but you don't see what could have happened. That's very true with communicating things like vaccines, where all those illnesses that you prevent, vaccine preventable diseases, we don't see them. And then people become less concerned about them than they would when they're right in front of them. And that means that oftentimes these efforts they're the victims of their own success, because as soon as we figure something out and improve it, money shifts somewhere else as opposed to supporting it. And finally, just because I see the time and I do want to wrap up, the second TED talk I gave, it was in Northern India, so it's TEDx Chandigarh, you can just search my name. But it occurred to me that because I've done so much work with media and communications and who's my audience, I realized I could continue preaching to the choir of everyone who's on the call here and, educators, pediatricians, social services, anybody who works with children and families and communities. And I get a lot of nodding heads and people are very supportive. But for a while, I got a little down about the fact that if we didn't convince policymakers and business people to support the kind of work that we're doing, we would continue to chase scraps for funding, and then it would be really an uphill battle. So I intentionally, and I tell the group here, I intentionally picked language that I knew doesn't sit so well sometimes with those of us who care about children as children and the humanism of medicine and things. But I picked a decidedly the language of business, economics, and policy. And I gave a TED talk where I figured, you know what everybody and their second cousin wants to talk about? It's not trauma-informed care and ACEs, right? We try to get it in there. Job skills, workforce, and innovation and leadership is a really good one. And what I did was I took those skills, and I always say, listen, in the world of business, if you want to get a Fortune 100 CEOs, you say 21st century skills, World Economic Forum says 2/3 are these soft, non-cognitive, and other skills. Communication, collaboration, teamwork, adaptability, resilience, empathy, perspective taking, the ability to, fail and adapt, resiliency, and you will get every Fortune 100 CEO to nod their heads. And I will tell you this because I've spoken to global business leaders summits on the subject. What I decided to do is say, right, now let me show you, let's go further upstream. We heard a lot of talk about looking upstream today. Let's go further upstream, and I will show you what those skills look like during their foundational development in the first 5 years. And oh, by the way, really cool brain science to back it up. And that framing, I will tell you, has worked. I've found myself in places I thought I'd be sitting next to Stan in an academic teaching hospital somewhere, maybe as a residency director, or as my husband's parents were afraid that I wanted to be Surgeon General. And what I've found myself doing is presenting to the US Chamber of Commerce the case for investing in early childhood to the British Parliament, and at one of the more recent annual meetings of the World Bank, because they were launching their #InvestInPeople campaign. And while I do not think of children as youth human capital, I will tell you that there's a lot of the world that does think that way. And if we can get them to think along the lines and understand the good work that everybody here is doing, I think we stand a much better chance of moving forward a field that obviously I'm very passionate about, and that all of you do such great work in. So again, I'm honored to join the group, and I'll just end there for the sake of time. Oh, Sandy, I think you're still muted.
Sandy, we cannot hear you. You're on mute. Zoom, we've all been there.
Yeah, I'm sorry, guys. Thank you, Laura, is what I said. And hopefully a lot of your ideas are so useful for people who want to be advocates or are advocates for all of this. And because you take us, not it's that issue of using cost figures is so vitally important if we're going to get to legislators, because they want to hear the hard stuff, but what really makes it real is the money stuff. Let's face it, it's America. Angela, I have a question for you. What pre-visit questionnaire do you give at your standard wellness visit? Like, how does the process work?
Yeah, no, the way that we work is when the young people come, we talk about confidentiality. We provide confidential services. We say to them, as per New York State law, except if there is abuse or you are thinking of suicide, or somebody's going to get killed, obviously we cannot. So we say that at the beginning. And then I am interested in knowing what the young person is thinking, feeling, and doing. So I sit down with them and have a conversation. And I then ask all these things. We have something in the electronic medical record, and if people are interested, I can send it through a screenshot to Jesse to distribute. But I just have a conversation with the young people about those things that I have learned that are really core, and that if they are not identified and addressed and given the opportunity, they will not necessarily do well. So that's
Good.
how I work.
Thank you. Stan, how are you going to get to the hot shots in medicine to bring about changes in medical education?
That's a great question, Sandy. I think it's going to take a wide coalition to put pressure on leadership in medical education. And I think, and to give our leaders the benefit of the doubt, I have found that at least in my sphere of influence here in Atlanta, when I can get in front of a leader, or when students can get in front of a person with some influence and just talk about ACEs, I mean, the topic speaks for itself and it's magnetic. I mean, people get it. I think people sense that what we're doing in healthcare feels like we're spinning our wheels. It's not efficient. We're too focused on outcomes and not the process. We're too focused on the revenue instead of actually investing in our people to promote healing. So I think leaders are frustrated too, but they're obviously pulled in many different directions. But it's going to take pressure, and students are great at putting pressure on
Exactly.
They are savvy. They will do it.
We when we did the urban ACEs, Roy Wade and I met with the board, the medical board people. That's one way to go, because if there's board questions, then they're going to be taught. Mags, can you expand a little bit on some of the really innovative Medicaid work you're doing in Oregon?
Yeah, I think that all of the panelists today have lifted up examples of things that need to be happening, and we've got some of those going on. Some of them I'd like to import to Oregon. So if any of you are interested in moving to Oregon, that'd be great. I think I'll mention two real briefly. One is called Project Nurture, that we started just looking at our data, and that's maybe one of the strengths of our positioning, if you will, in the system, is that we kind of can see the gaps where people are not able to access, and what that means for them in their lives. And what we noticed was that women who were pregnant and had substance use issues were getting kicked out of both systems. So obstetricians, family docs didn't want to take care of them if they were using substances during their pregnancy, and the substance abuse system didn't want to take care of them if they were pregnant. And we just saw that over and over. And we also saw a connection over into the Department of Human Services, who, if a pregnant woman using substances did come to medical attention, they might very well be kind of reported to DHS, and their babies would be taken from them. So we kind of flipped that on its head, using information from those women about what would be helpful to them, realizing that peers and doulas supporting them throughout their pregnancy was a good first step, just making the whole situation safer for them. We struck a deal with the Department of Human Services where, as long as the person was, still kind of getting support and things were going okay, their babies wouldn't be taken. Supporting them, whether or not they gave up substances, that was kind of beside the point. They were certainly offered the opportunity, but it wasn't a necessity. They were given education, support, housing, social connections, all of the things that have been talked about here. And then for a year following birth, support for the best kind of attachment as much as possible, again, using peers and coaches and that kind of thing. So trying to demedicalize the whole situation, really keeping in mind the whole perspective of trauma. And what we found was that, first of all, from to Dr. Laura's point, using the business case for that, is we found that our babies needing an NICU, the neonatal intensive care unit services, fell by, I don't know, some crazy statistic like 94%, because these are people who otherwise weren't getting prenatal support, and then coming to attention sort of at the last minute at delivery. So that was the business case was easily made because it saved so much money. But more to the point, the women themselves felt so much more acknowledged and seen and accepted. And they were able to keep their babies in almost all of the cases that we studied, 300 consecutive cases, got to keep their babies, but also got other children that they had lost, they got them back. And so that for us was a huge win for the system. So that's one example of kind of trying to move upstream, trying to pay attention to those first 1,000 days or even pre-first 1,000 days. The other quick thing I'll say is that we're currently working with the federal and state government to make housing a Medicaid benefit. Understanding that housing and health are pretty irreparably connected to each other, and that might be a really important thing we can do. So those are a couple of examples.
Great, thanks, Mags. Laura, let's pretend that every single person on this webinar has committed to going to their hospital and meeting with the CEO of the hospital. And unfortunately, though, all of the CEOs are only going to give them 2 minutes. What are those vital things that they need to get across to that hospital administrator?
Well, 2 minutes is a really tall order. And again, I would know you're a hospital administrator because I don't want to paint them all with the same brush stroke as only being focused on revenue and things.
Just really busy.
But yes, but what I would suggest is, first of all, especially within the medical community, the fact that we can rely on things that are really evidence-based, peer-reviewed journal articles and research. We've got the work that Maggie's doing in health systems and what Angela talks about, where she says, what's her outcome measure? And we see impact in all these areas, helps to reinforce it. I use a particular example for people is I say, what if, and this works well with hospital administrators and healthcare people. What if I, as a pediatrician, tell you that the single best treatment for this 4-year-old girl's asthma, pick a medical condition, bread and butter pediatrics, very common. What if the single best treatment for this girl's asthma, and she's been coming to the ER and then getting admitted to the ICU, and let's just say $100,000 cost to the healthcare system, because they like to hear dollars, right, is $100 of legal services for her mother. And then what I tell people is that is a real example from Cincinnati Children's Hospital. That 100 and 100,000 was just for example. But the point being, it gets people to think about these social determinants of health. And in fact, the head of the Children's Hospital in Columbus, Ohio, who's known to be one of the top sort of healthcare finance people, I had the chance to talk to him about, is this sort of health system transformation to wellness and prevention and things going to come from within the traditional healthcare system and children's hospitals instead of outside? He said, only if they partner with all these other people in the community. He said, I can't cover housing and transportation and all the food insecurity issues and all these other things, but they have such a huge impact on our traditionally measured healthcare outcomes and the economics of healthcare that we'd better. So that's what I think is really do pull in some of those numbers. The other phrase I'll leave you with, the really quick, easy one, is say, tell me which return on investment you want to talk about. The individual, the community, or the economic financial. Oh, guess what? They all tell you to go ahead in the same direction. Investing early, when you the first 1,000 days, sure, but some people say 1,000 days meaning prenatal, and then the first 2 years, whatever. If the earlier you invest, the bigger the return. And I always say, not only is it an economic financial return, but to quote the former head of the Minnesota Federal Reserve, he said, Laura, please add in, of almost all public dollars. It's not just an economic return to whoever, right? It's public dollar return for those early investments. We have to sell them on the benefits of prevention. And it's a tough sell, but we have all the data for it.
I knew you'd do it. All right, everybody, get out there, get those calls made, get on the line, get appointments with those administrators, and get moving on this. Okay, Jess, back to you.
Sandy, thank you. To all of our panelists, thank you for such a rich, wonderful, diverse discussion. Again, it's just so incredible. Laura, you made my job easy. Usually I come in and talk about how to get involved. You spelled it out better than I could. So thank you. Please join the National Trauma Campaign, join PACE's Connection, become part of this growing movement and continue to spread that to others. So that way we speak as a community. We hold up the megaphone instead of just a microphone. so that others with lived experience have the opportunity to share their stories as well. That's how we are going to move mountains. Speaking of stories of lived experience, I am pleased to introduce Marcia Morgan, who was the Chief Operating Officer for Truman Medical Centers in Missouri for 23 years, is a founding member and board member for the Campaign for Trauma-Informed Policy and Practice, and currently the CEO of Resilience Builders, to talk about her experiences in the medical system and now outside of it, helping to change the medical system. Marcia, over to you.
Thanks, Jesse. Okay, so I'm a little overwhelmed with all of the wonderful presentations that have already been done. So let me just really tell you my story. The Missouri Department of Mental Health in 2009 offered us the opportunity to become early adopters to create trauma-informed organizations. And at the time, I was the Chief Operating Officer of Behavioral Health for Truman and thought I knew a lot. Found out I didn't know quite so much, and actually found out that we were not addressing the root cause, and came back to my hospital and decided that we were going to become, or work to become, a trauma-informed organization. And I want to give you kind of the process, and it goes exactly, I think, ties into what Dr. Jana was talking about in terms of how do you get your message across. And one of the things that I would say is I went to my leader, who was really unique in many, many ways. And I knew what his priorities were. And his actual priority was addressing the epidemic of violence. And so my message to him was, if you really want us to address violence, then we need to back up, and we need to talk about trauma, and we need to, and again, thanks to, Sandy's excellent work on trauma lives in the cell, and, all of the, and how that goes out to the body and affects the community. Every time he asked for an innovative idea, I kept talking to him about, we're going to address violence, because I knew he would hear that. When I talked to my medical staff, I talked about the research, because that's what they wanted to hear about. I tried to talk to him about outcomes and, saving money and all that. And what they wanted to know was, what's the research tell us? And so again, as we think about, I guess my story is, if you really want to get buy-in, think about the messages that you're taking to people and really find out what their burning issues are. And because this is the root cause, this does make a difference. So as I presented this information, I presented it to our management staff, and we had hundreds of people in our management program, and we had monthly meetings, and I provided for them one-page sheets that they could take to their staffs. So handouts about transference, a lot of handouts about, here's what trauma-specific practices are, here's what our universal practices are, because people didn't always want to know let me say again, overwhelming majority were medical folks. So they thought they knew a lot more about the brain probably than they thought I knew. But we would, and then I was invited to departments. And one of the things that I learned pretty quickly is every department is every department. And so what we worked on were finding department-specific practices that they could, that they might impact. So I'll give you a really quick example. We have a sleep center, and our sleep center is located in a hotel. And we're asking, Truman Medical Center is largely was a public hospital, is a private not-for-profit, truly in the sense of the word, and we are the we serve largely Medicaid and Medicare folks, largely Medicaid folks and uninsured. We have a variety of ways that we are funded anyway. So part of, again, the pain point for our sleep center is, we get these people, we do these sleep studies, and then we have them, we give them CPAP machines and they don't use them. What's wrong with these people that they don't use these CPAP machines? And so as we started talking about trauma and we talk about the triggers, if you've been sexually abused, putting something on your face could really be a trigger. They were like, oh my gosh, we need to change our practice. And so they put in place pre-calls, pre-visits, so that our people, this is a big fancy hotel. It's not like a Motel 6. It's one of the big fancy hotels, and, giving people the virtual tour of and talking to them. They also started recognizing when they had the female patient who would come in the room and she would sit in the chair and she would hold on tight to her purse, that they needed to do some more relationship building. They needed to check. When I went, so they made lots of changes. Our cardiology folks who did the EKGs, they were like, oh no, you mean we don't ask if it should be a male or a female when we're putting electrodes on somebody. We just stick them on there, and then we wonder why people want to punch or people get aggressive. So I say all that, Jess, just to say, it's remembering that when you get to the very ground level, it's really about practical application and really, again, trying to reach people where they are. And really thinking about, when I first started at Truman, I had the chair of ophthalmology, and he was like, I don't know what you're doing here. And then 6 months later, he was like, hey, you need to come and talk to my people. I'm telling people they're going blind, and we don't do anything about their mental health. We just say, you're going blind, you've got macular degeneration or whatever it is. Anyway, so that's, so again, get into the specifics for people so that they know what they can do almost immediately. And the other piece that I think happens when people have a better understanding of the patient is they also have a better understanding of themselves and what's happening to themselves. And so we're really spending today a lot more time on how do you take care of who you are so that you can take care of the person that's in front of you, and really understanding that at a deeper level. So I hope that's kind of what you want me to talk about, but that's it.
It's your story, Marcia, and we love you for it. Thank you so much for sharing. Thank you to everyone. It's amazing how 4 hours, there's so much information, and yet it seems to fly by. Both times so far, I'm sure that'll be the experience in the future as well. One quick statement so that folks are aware. Deb Berkey, Deb, if you're still on and don't mind putting your email in the chat for folks as I'm saying this, if not, I'll get it out after I'm done, is bringing together in partnership with CTIP, a community of practice for healthcare organizations that are looking to become trauma informed. And so if you have interest in being a part of that community or community of learning, as well as I told Deb, who just put her email in the chat, that I would start saying instead of community of practice and learning, please feel free to email Deb. We would love for you to be a part of that community as we continue to grow this movement.
Jesse, can I get the final word in?
Go for it, Dan.
Sure. Because Dr. Janet's story about the hospital administrator really pulls back to the comments I made at the very beginning of the workshop, which is that no one sector can do it by itself. And that what we need are community cross-sector trauma-informed coalitions that involve all the sectors. It's It's what CTIP keeps preaching, and that's what we hope everybody on the phone will work to achieve in your community, is pull together those cross-sector trauma-informed coalitions and have those coalitions then become part of a national force to change attitudes that we've been hearing about all day. So please go leave this workshop and go out and create a coalition or join a coalition or strengthen a coalition, because that's what's going to accomplish. And I think Dr. Jana's point really nailed it. Yours,
Yes.
Jesse.
Go ahead, Jess.
Oh, I was going to let Denny please take it away. The one thing that I'll add is just to remember that in case you didn't get it in the chat that Denny put, the breakout room link is on the National Prevention Science Coalition to Improve Lives website, where you registered for this workshop series, and it is again in the chat. But Denny, please take us home.
Take us home. I think we are home. I think we have found our home. I think we now know what our mission is. These two panels together have been so instructive about ways that we can really work intimately and in an integrated fashion with these systems, with the healthcare and education systems from the inside, not from the outside. And so I think that the lived experiences of our expert speakers were really instrumental in pushing us forward. And we're going to, as Dan said, continue on with these how-to workshops, how to work with this and how we can network to create these tentacles in between all these different coalitions across the country. So and I want to remind people this will be shown again. It will also be available on our respective websites. And it's just hard to add to what has already been said, and it's 5 o'clock Eastern time, but I want to thank everybody. I hope to see you in 2 weeks for our next set of panels. And if anybody's interested, last 2 weeks ago it went really well. If you want to engage with others and really actually be able to talk to each other live, and sort of live, well, you know what I mean, in this virtual world, but actually have an interaction and not just look at talking heads, please do join the breakouts. I'm going to continuously put it in here because the thing just keeps scrolling. But and I will stay on so that people can get to it. I'll just keep putting it in the chat, and I will keep this open for a few minutes. This is going to be a different Zoom room that you will go to. So thank you so much. Jesse, any parting word?
Thanks, Denny. Just to all of our participants, keep an eye out for an email from me in the near future about a survey on how we can continue to improve. We got so much information, and there will also be more information on the recordings, as well as that the showing, if you will, for next Friday, where we'll show the second half of this panel again.
Right. Right. We will, now that you're registered, we know where to find you. So we'll be providing resources and slides and videos. So take good care and have a wonderful weekend.
You too.